obstruction of the descending aorta, this is now understood as a cardiovascular syndrome. It presents numerous anatomical variations, as we will see shortly. In this MRI reconstruction, a typical aortic coarctation is identified with narrow than the aortic isthmus, its most common classic presentation, accompanied by dilatation of the ascending aorta without involvement of the left subclavian artery. In the left reconstruction, we observe a neonatal aortic coarctation with severe hyperplasia of aortic arch, as narrowing of the aorta proximal to the left subclavian artery. This MRI reconstruction shows tortuous and dilated aorta with severe aortic coarctation. This is the case of the patient with aortic coarctation repair as a new word on his long-term course. And in this MRI, we can see a strange place in the aortic coarctation. You can see that aortic coarctation is a condition that at the long term involves many variables which we'll discuss during the presentation. And there are an increased cardiovascular morbidity and mortality in the follow-up despite successful repair in childhood. It has been studied and shown that these patients have a reduced life expectancy with a prevalence of hypertension ranging from 25% to 68%, and mortality in this group of patients is determined by hypertension and vascular disease development over time. Here I present the KOALA and KOAFO studies among the first and follow-up on patients with corrected aortic coarctation over the long term. They analyze the importance of hypertension development even in patients without recurrent aortic coarctation. To me, this study forms the foundation of subsequent research over the years. They show a prevalence of mass hypertension of 25% in patients operating with an aortic coarctation operated without recoarctation. And both studies highlight the importance of arterial stiffness in long-term outcome. The hypertension is the most common long-term complication after completed relief coarctation of aorta without residual arc obstruction. The onset of hypertension in patients with corrected aortic coarctation can be related to several factors, which we will discuss. The presence of residual lesion at the site of aortic coarctation can cause hypertension. Therefore, it is essential to highlight the difference between residual and recurrent aortic coarctation. Residual aortic coarctation occurs when immediately after treatment, a significant volume remains, indicating that the treatment only partially resolved it. Recurrent aortic coarctation refers to those where initial resolution was successful with no significant residual gradient. Over time, the coarctation reappears, often during periods of rapid growth, such puberty. Up to 20% of patients may experience recurrent coarctation during growth. The initial approach to addressing the lesion also determines the difference in long-term outcome and vascular complications. This is closely related to the next point, which is the age at which the aortic coarctation is resolved, because the longer exposures to aortic arc hypertension may cause irreversible damage in the arteries. As I previously mentioned, the anatomical difference of aortic coarctation results in various techniques for its resolution: end-to-end anastomosis, extended end-to-end anastomosis, subclavian flap repair, use of protective material parts, or in the case of pediatric or adolescent patients, resolution without arthroplasty and stent placement. For example, the subclavian flap may affect the elasticity of the segment because there is no aortic tissue. Over the years, this possibility has developed, and we have learned, for example, that the use of prosthetic material is associated with high rates of recortation and increased risk of aneurysm as shown in the arrow. The timing of aortic coarctation resolution is also related to the likelihood of development hypertension in the future. Some research that analyzed vascular remodeling in adults with operate coarctation of the aorta and its relationship with the age at approach concludes that the age of correction has no relationship with the subsequent development of peripheral or central vascular remodeling because coarctation of the aorta is a systemic vascular disorder that progresses to vascular and target organ damage regardless of the age of correction. But in this imaging, we see difference in the risk of recurring antihypertensive medication over the lifetime, depending on the age of resolution, neonatal, infant, or child, and this observation is maintained in other research. Another important factor is the morphology of the aortic arch. Aortic stent could be the cause of structural arterial change and vascular remodeling related to GR stress. The ventricular arterial coupling in the early aortic arc allows of normal function. However, cause of contractile aortic arc morphology, as seen in the imaging, there is a higher prevalence of hypertension. There are functional and structural abnormalities in the arterial wall in patients with coarctation of aorta contribute to hypertension. Activation of aortic vasoreceptors, the sympathetic system, activation of heart system, increased arterial stiffness, and shear stress of endothelium may be involved in the mechanism of hypertension. In patients with coarctation of the aorta, vascular activity is impaired, and there are studies that show that the gradient in the aorta may be reduced and the left ventricular mass may be improved, but the arterial structure and function remain abnormal. In summary, the patient with repaired aortic coarctation during follow-up we must evaluate the possibility of recurrent aortic coarctation, the development of hypertension, cardiovascular risk, associated lesions such as bicuspid aortic valve, aortic dilatation, and aneurysm. Thus, we know this patient can develop in the central nervous system. So, for follow-up, the recommendations include measure blood pressure in 4 limbs at each checkup, performing echocardiograms to assess the gradients of the repair site and associated lesions at bicuspid aortic valve, evaluated ventricular mass to rule out ventricular hypertrophy. ABPM is recommended annually due to the possibility of high hypertension, which has a prevalence of up to 25% in the population. Imaging studies like CT or MRI are recommended every 5 years in asymptomatic patients to evaluate anatomy and rule out complications. In case of such a lesson of echocardiography,
arterial
Of course,
stiffness yung sa
these
carotid,
studies should be
yung
performed as
workshop
supervision
natin.
or without the diagnostic.
Ano ba yung cut-off
Exercise
mo?
dating
Less than
and
0.42
ergometry is recommended to evaluate the blood pressure
Pero yung
during exercise, and studies of arterial stiffness such as weight velocity are still in a research stage. It is always important to emphasize lifestyle measures like maintaining an effective weight, engage in daily physical activity, following a healthy low sodium diet, and avoiding alcohol. It's important that no specific disease entities have been said of targeting in children with impaired rotation of the aorta.
face pala.
When
Tsaka
hypertension is confirmed in this patient, the
Pangatlo lang yung
recommended
beta
medication are ACE inhibitor and beta blockers. So beta blockers are also used because these patients often have aortic dilatation, which also benefits well from this medication. Here is my first case on the ABPM in patients with atrial fibrillation of the aorta, where we can see a significant prevalence of mass hypertension and nocturnal hypertension, which reinforce the importance of ABPM in this population. Here I share with you our experience in patient follow-up with coarctation of the aorta corrected in the hypertension clinic. It was a poster presented at each Congress in 2024 based on the retrospective analysis of 142 patients. Our population has 28% hypertension amongst those under 8 years of age, and it is increased to 46% among the eldest,
38.
considering that international reports that indicate that the evolution toward hypertension in this population is progressive. Overweight and obesity increase over the years too. It's very important to talk about physical activities and cardiovascular prevention measures in this population. And in this work presented in 2023 at the Argentine Congress of the Society of Hypertension, the longitudinal follow-up of a cohort of patients showed that 50% developed hypertension at almost 3 years to follow-up. And during that time, 62% of patients with hypertension had achieved control, demonstrating the importance of longitudinal follow-up. The follow-up of patients with repaired aortic coarctation, long-term adherence, the study of ambulatory blood pressure phenotypes, and endothelial and vascular change remain subject of study and ongoing challenge. Thank you very much.
Project on
Kaso inawakan ko
the
na.
large screen. Thank you. So hypertension is very prevalent in children with CKD, and depending on the underlying kidney disease and the stage of renal function or CKD, there are between 50 and 80% of patients with elevated or hypertensive blood pressure values.
Bakit kaya maraming mask mo? Bakit kaya maraming mask hypertension?
And the kidneys play a central role in the regulation of blood pressure. Together with the cardiovascular system, adrenal glands, and the central nervous system, they regulate cardiac output, fluid volume, peripheral vascular resistance, and are responsible for the development of hypertension. So, going a little bit more into detail in CKD, blood pressure is read by cardiac output and total peripheral resistance. And in uremia, by chronic PTH elevation, increased sympathetic tone, endothelial damage, we have increased vascular stiffness, vessel diameter is reduced by vasoconstriction, and we have an activation of the RAS. We have the renal disease with renal artery stenosis, maybe scars or cysts, also activating the RAS. We have reduced nephron mass in renal insufficiency with sodium retention, oliguria affecting fluid load, and also resulting in increased blood pressure. And the central role is mainly the RAS activation. So RAS activation is mediated by the key player angiotensin II, which goes to the AT type 1 receptor, which mediates vasoconstrictory, fibrotic, inflammatory, and antinatriuretic action. But there's also a kind of a protective arm of the RAS mediated also by angiotensin II, but also by some metabolites or fragments. And it's going to the type 2 receptor and other receptors as well, which mediate vasodilatory, antifibrotic, anti-inflammatory, and natriuretic effects. So the RAS is not always bad. Activation or of the angiotensin II receptor mediates aldosterone secretion, has a direct tubular effect and increases renal medullary blood flow, which results in sodium retention. You have afferent arterial constriction, increased renal vascular resistance, increase in intraglomerular pressure, which results in increase of filtration fraction, also in sodium retention. So hypertension results from renal disease, but is also a cause of renal disease, as we just heard. And just trying to bring these together. So if you have hypertension, you have increased glomerular filtration, which induces proteinuria and nephrosclerosis, also increasing protein excretion, resulting in a reduced renal function, and this again is driving hypertension. So you have a vicious circle between hypertension and renal disease, keeping it growing. So the main factors are hypertension and proteinuria and the RAS, but there are also other factors influencing kidney disease progression, as oxidative stress, smoking, diabetes, hypoglycemia, acidosis, lipid metabolism, atherosclerosis, uremia, and calcium phosphate, disturbances of metabolism and PTH increase, anemia, and the genetic background and underlying renal disease. But we will now concentrate on hypertension and a little bit on proteinuria, because one cannot come without the other. Hypertension and proteinuria have been shown to be independent predictors for the risk of chronic renal failure in the general population and for the progression of chronic renal failure in adults as well as in children. And that's a little bit more detailed flow chart. So systemic hypertension increases intraglomerular pressure, proteinuria, and proteinuria exerts some pro-inflammatory and vasoactive signaling, and at the end this ends up in a dysbalance between collagen matrix protein synthesis and tissue protease activity, ending up in matrix deposition and fibrosis, which induces tubular interstitial hypoxia, means reduced nephron mass, and then you end up here again with increasing glomerular hypertension, and you also have direct effects of vasoactive signaling on glomerular hypertrophy and pressure. And this vicious circle can be blocked by blocking the RAS system, and it's not only by lowering intraglomerular pressure, but also by exerting some anti-inflammatory effects. And there's one landmark trial, actually, it's the ramipril efficacy and nephropathy trial, which showed in adults with proteinuria non-diabetic CKD that ramipril treatment reduces the risk for kidney disease progression, significantly compared to placebo, but that was not only due to a better reduction of blood pressure. Actually, the difference was not so large between ramipril and placebo group, but due to a significant decrease in proteinuria. And there are more studies showing that ACE inhibition reduces protein and the overall risk for composite endpoint, mainly in these studies, of halving GFR, 50% loss of GFR attaining end-stage kidney disease. And also in two meta-analysis, it could be shown that the overall risk is reduced. However, has been shown that there's also some impact of proteinuria. So the risk reduction is in few studies significantly better in patients with proteinuria. So what do we know about blockade of the renin-aldosterone system in children with CKD? And there are, for example, data from the TICKET study with 850 participants, and the risk was adjusted for age, male sex, glomerular diagnosis, GFR, nephrotic range proteinuria, and other risk factors, and it could be shown that RAS inhibitor use reduces the risk of renal replacement therapy by 21% to then 37%, compared to other antihypertensive drugs. And in the 4C study, it has been shown the other way around. These were patients aged almost 40 years with a mean GFR of 27 ml, and there were two groups matched. Patients where the RAS inhibition was discontinued due to increased creatinine, hyperkalemia, or symptomatic hypertension, and they were compared to patients with ongoing RAS inhibition, and the discontinuation of RAS inhibition in children with CKD was associated with an acceleration of the decline of GFR. Okay, but what should be our blood pressure goal? And these are data from adults, and nicely shown that there's a direct linear correlation between blood pressure control and GFR decline, with the fastest decline in those patients with untreated hypertension. And you can now conclude that it would be best to have a tight or a blood pressure control as good as ever possible to preserve kidney function. So what do we know about intensified blood pressure control? And these are data from the ESCAPE trial, where patients with RAS inhibition or at the ACE inhibitor ramipril at a fixed dose of 6 milligrams per square meter per day, and were randomized to conventional treatment, which is the 50th to 95th percentile, or intensified below the 50th percentile, and the blood pressure value we evaluated was the mean arterial pressure. It showed that patients with intensified blood pressure had a significantly better renal survival, and that the risk was significantly decreased. And this is also shown by a meta-analysis of 11 trials. These are pediatric and adult trials combined. And there was also overall a risk reduction for end-stage kidney disease and the composite outcome. But when this was divided into patients, subgroups without baseline proteinuria and with proteinuria, it's the case that patients with proteinuria have a benefit significantly, while those without proteinuria had no significant benefit. And there was a 10 millimeter mercury reduction in systolic blood pressure, and it resulted in an overall reduction in the risk of kidney failure of 22%. So these findings were incorporated in the recommendations of the European Society of Hypertension for blood pressure targets in children, though in general it's recommended to target for blood pressure below the 90th percentile for age, sex, and height-specific percentile, but for chronic kidney disease, the percentiles are lower. It's for Europe, the 75th percentile in children without proteinuria and the 50th percentile in children with proteinuria. And 24-hour ABPM is strongly recommended, as these recommendations are based on ABPM measurements, and the goals in the European guidelines for ABPM and casual BP are the same. In the American guidelines, the threshold is lower, it's 50th percentile irrespective of proteinuria, and that's very similar to the KDIGO 2024 guidelines, where it suggested that children with CKD should have an ABPM level lower than the 50th centile, or of a systolic blood pressure in the range of the 50th to 75th, related to age, sex, and height, unless patients suffer from hypertension. And renin-angiotensin system inhibitors can be used. So what antihypertensive agents do we have? So I think we have a lot of experience also with some of these drugs are not licensed for the use in children. First line drugs are RAS blockers, calcium channel blockers, diuretics, and beta blockers. Second line vasodilatators, adrenergic blockade, potassium-sparing diuretics, and central nerves acting agents. And of course, chronic kidney disease and microalbuminuria, post-transplant hypertension, ACE inhibition or RAS should be considered due to the pathophysiological action. There's some substances in the pipeline where which have an effect on blood pressure, but also have some neuroprotective efficacy. But I think for the sake of time, and because some of these will be addressed in other talks, there will be a talk on SGLT2 inhibitors, and there will be also a talk on new antihypertensive drugs, so I think I will skip this. I will just go. Just to my last slide with this overview. So there are some very interesting substances, maybe in the future, but we then still have to see whether they are also safe and effective in children. And potential antihypertensive drugs for children with added value, which will be available, maybe licensed in the near future, maybe SGLT2 inhibitors and non-steroidal MRA. There are both studies on the way. And for special kidney diagnosis, IgA nephropathy, or FSGS or Alport, also sparsentan might be an option. So, in summary, the kidney is victim and culprit in hypertension. Renal hypertension is mainly driven by the RAS activation and altered pressure natriuresis. It's an independent risk factor for renal disease progression, and we can protect the kidneys by blood pressure control, and by RAS inhibition we can prevent glomerulosclerosis. We know that we have a high prevalence of uncontrolled hypertension, so we have to be very careful with our patient and to check blood pressure regularly.
73 without protein.
I think I missed something, sorry. So, but we also know that ongoing or recurrent proteinuria is a risk factor for progressive renal failure, even with excellent blood pressure control. So if you treat patients with DKD please also consider Optimus antiproteinuric treatment, and maybe you also may have to consider combination therapy. And there are new antihypertensive and renoprotective drugs underway, but data on long-term efficacy and safety data are still needed. Thank you very much.
Thank you, Mary. Thank you for a very nice summary. And I think we have time for a few questions. Right. Let me start. Can you tell us, how did you guys come up with the recommendation for 50th percentile and 75th percentile for casual blood pressure?
Well, that's extrapolated actually, because we, for the evaluation of the ESCAPE trial, we looked at the MAP.
So basically what I'm saying is that the recommendation for casual blood pressure right now are based on ESCAPE trial that did ambulatory blood pressure monitoring, right?
Yeah,
Right.
actually it is.
So the bottom line, I think we don't have a really good data to know what really should be our casual blood pressure recommendation, because ABPM and casual may be not the same.
No, but what's similar when we did the analysis, but the main outcome was the ambulatory blood pressure measure.
Dr. Flynn?
And I didn't mention hot kit because it was a cardio.
So if you look at the renin-angiotensin-aldosterone system, use of AT1 receptor blockers shifts the effect of angiotensin to the ETB receptors, which have more anti-fibrotic, anti-proliferative, and beneficial effects on that. It's a good half of the system. So, what are your thoughts about favoring, ARBs versus ACEs to maximize the beneficial effects of the other side of that system?
Yeah. So in fact, we changed our clinical practice from ACE to ARBs because the side effect to the cuff is less, which might also be a problem in smaller children. You never know if it's an infection or not. And we also saw that we had an ESCAPE phenomenon in the ESCAPE trial, that after 3 years proteinuria reoccurred, and that might be also a reason to change from ACE to an ARB, because of the risk of this aldosterone rebound is a little bit less.
So, thank you, Elke. I just really wanted to add a comment to what Mark was asking. So, for the same kidney patients, we do have a trial to show that a lower office systolic blood pressure done in a standardized way is helpful. So, I think what the clinicians need is not two separate targets. They need an integrated target, and we saw some data for that. And also, your data from the CKIP cohort already shows that if you target a lower office systolic, then the chances of having mast hypertension are very low. So I think putting some of those things together, and not everything can be an RCT, and certainly there are questions around equivalent studies and how useful they are. A lower target for both of those is probably the right way to go.
Yeah, I think the correlation in this point between the casual BP and the ambulatory is not so big, but it might be not 100% correct to say it must be the 50s, but we can work on it.
But I can tell you that, maybe it's a hard question, but don't worry. In the United States, we adopt the same recommendation, okay? Any other questions? Well, thank you very much.
Hi, I will introduce Dr. Mark Nick Fitness, Professor of Pediatrics, University of Cincinnati College of Medicine, Director, Clinical Translational Research Center, Cincinnati Children's Hospital Medical Center, Division of Nephrology and Hypertension.
Well, thanks again. So let me start with this slide. It's a old study, right? So it's 20 years old. This is Napartic data, and you can see the prevalence of hypertension in patients on maintenance dialysis. So just pay attention to 2005, about 50%, right? You follow them for a few years. If they're still on dialysis, the prevalence is still about 50%. Now, that's after this study. There have been a few more studies looking again at for prevalence of hypertension, and this is very nice summary published by Fabio Vialonga in 2018, looking again at prevalence of hypertension, and you can see here this is the prevalence of hypertension, right? But it doesn't matter how you define it, right? You can define it by controlled hypertension, untreated, uncontrolled, patient taken on antihypertensive, or uncontrolled hypertension in treated patient. The prevalence is above 50%, right? 60 to 70, so it's quite high. And this study has been done between 2005 and 2017, something like that. There are two more studies that I think very good, and this come from International Peritoneal Dialysis Network, the first study, published in JASN more than 10 years ago. And you can see that in peritoneal dialysis, the prevalence of uncontrolled hypertension was about 45%. The more recent study from the same group, but now using International Pediatric Hypertension Network, that was just published in last year in KI report, showed that 55% of patients had on maintenance hemodialysis had uncontrolled hypertension, and the subgroup of this patient had ambulatory blood pressure monitoring, and you can see here that 81% had uncontrolled hypertension. Now, of course, doesn't matter, it was 2005, now we're back to 2025, right? We are not doing a good job controlling blood pressure in patients on dialysis. Okay, so what are the causes of uncontrolled hypertension? Of course, we all know. And by the way, most of us here are nephrologists, I understand, right? If you look here, this is one of the first studies that we did through Pediatric Nephrology Network Consortium, PNRC, and we just look at different centers in the United States. This is a 10 dialysis unit. We decided in 2006, get like September of 2006, and look at all blood pressures that been recorded during that month in all these centers, and you can see that pre-dialysis, the first week of dialysis, mid of dialysis, and of course post-dialysis session. So it's all been done, and you can see the difference when you at the beginning of dialysis session, prevalence of hypertension was 59, and after end of dialysis session, 3 to 4 hours, the prevalence 42%. So of course we remove fluid, blood pressure got better, right? Nothing new here. A couple other studies. This again, a study for Fabio, published in 2015. He looked at inter-diabetic weight gain and blood pressure. You can see nice correlation. Very similar study was done, again, another study, but in this second study, they used ambulatory blood pressure monitoring. And what you can see here, pre-dialysis, causal blood pressure, the prevalence of systolic hypertension was 38.5, diastolic 23. They look at post-dialysis session. Again, it's significant improvement to about 7.7%. But then, in 24 hours, right, using kBPM, prevalence goes up. And right at the end, before next dialysis session, we have the same result. So it's again back to 38%. So definitely we see the shift of the fluid, and that's what leads to change in blood pressure and change in prevalence of hypertension. Now, other causes of uncontrolled hypertension, this again from an original study, And you can see here that baseline hypertensive patients had higher level, receiving antihypertensive medication, leg raise, younger age, acquired kidney disease, hemodialysis versus peritoneal dialysis. It's all these factors associated with worse hypertension. Other causes, maybe arterial stiffness, using of EPO, steroids, calcineurin inhibitors, secondary hyperparathyroidism, or previous renal transplant. All these factors been known to associated with higher rate of hypertension. I will focus more on the most recent study because I think this is a very important study that from KI. And you can see this is table looking at general mixed model analysis of factor associated with systolic and diastolic blood pressure. Okay. Again, very similar to 2005. You have younger age, number of antihypertensive medication, acquired kidney disease, and dialysis vintage. But here they use it hemodialysis versus hemodiafiltration. So a patient on hemodialysis did worse than a patient with hemodiafiltration. But one important advantage of this study versus all other studies is you're looking at interdialytical weight gain, okay? And that we'll see here, very significant association. The more interdialytical weight gain, the, of course, more going to be hypertension. And for each 1% increase in relative interdialytical weight gain was associated with 19% increase in systolic and 9% increase in diastolic blood pressure standard deviation score. So definitely volume is important. But they also look at what factor associated with interdialytical weight gain, okay? And you can see here, not surprised, those with urine output had better outcome, or those with diuretic use, very interesting, also had better outcome. And also no surprise that higher dialysate sodium or dialysis vintage, again, hemodialysis versus hemodiafiltration were all associated with a higher interdialytical weight gain. So what to do, right? So I guess we know what to do, right? But first, we need to define blood pressure targets. And that's not easy. In 2005, KDOQI guidelines said optimal systolic and diastolic blood pressure should be below 95th percentile. For some reason, in 2021 KDOQI guidelines, there is no recommendation for pediatrics where we should be, okay? 90th percentile, 95th percentile, 50th or 75 percentile, we don't know, okay? Basically, there is no studies to support optimal blood pressure targets in children on maintenance dialysis right now. In any case, again, I go back to another review by Fabio when he looked at steps to achieve blood pressure, right? And you can see here that dry weight management, sodium intake, sodium and fluid removal by dialysis, it's all very important. But what they all indicate, volume control, right? And you know, if you look at all other studies, basically the consensus that about 90% of our management related to blood pressure should be volume control. Using of other methods like using blood pressure medication, that's 10%. So think about it. So another input, if you're going to go to this article, I really like this because it's, again, this is blood pressure and volume management and dialysis, conclusions from KDOQI Controversy Conference. And they just give you multiple steps how to assess dry weight and how to manage hypertension. So the first step is a dry weight and volume assessment, okay? Again, this is a mainstay. You know, we have so many different tools, but again, we have to go back to basic, okay? And make an assessment, physical assessment, look at the history, and this is very important, okay? Blood pressure, again, I'm not completely agree with this because the previous study I show you that higher blood pressure associated with volume, so I think we still have to think about it. If blood pressure is poorly controlled, we always have to go back and look at the volume and manage fluid management. But then they comment on this test, which is the lung water ultrasound, okay? And probably this is the most sensitive and specific test looking at fluid management in patient on dialysis, okay? So what it is, water accumulation in the lung, interstitium thickness, and intertidal septa. The thickening produces a reverberation of ultrasound beam and generate visible bundles, narrow basic going from probe to the edge of a tomography screen. And these bundles are true ultrasound equivalent of B lines. So B lines, you can see here, right? And there are studies in adults show that probably 3 lines will indicate overfluid. Some study will say 5. There are very few pediatric data, only maybe a couple very small studies, but again, I did between 3 to 5 lines. If you see them, probably a patient has fluid overload. What about bioimpedance? Again, this is a nice tool. Again, it tells you different, basically it's an electrical current looking at different tissues, and we have normative values for this, and the machine is available, but it's not cheap. It's about $20,000, at least in the United States, one of those machines, okay? What about relative blood volume monitoring? Many of us use CreatLine, right? It's a good tool, but I think the most important is not just single one tool, another tool, the combination of tools. That will give us probably the best assessment of patient dry weight and volume status. Second step is fluid and salt restrictions, right? There have been multiple studies and meta-analyses, and it's difficult. The difficulty is adherence, right? Because take our adolescents, right? They're just not adherent. And you can see the first study, 16 studies, second is 23 studies. It's just poor adherence, okay? But we still need to talk about it with our patients, with the families, okay? Cato 2005, low salt intake with less than 2-3 grams of sodium per day. So that's a current recommendation, probably very reasonable. The next is dialysis prescription. This is step 3, and again, we can talk about sodium, right? High dialysis sodium increases intradialytical weight gain, but at the same time, it prevents hypotension during dialysis session, right? So really, we have to think about it. There are multiple studies now in meta-analysis in adults actually saying that low salt in dialysis, it's probably not good, okay? And one of the big studies in adults, like meta-analysis, showed that sodium 138 and above was associated with better outcome as far as overall mortality data in adults. Calcium is important, magnesium is important, so I think we're all aware of these electrolytes. Hemodiafiltration is better for blood pressure control than hemodialysis. This is data from 3H study with Roxana Shroof and the first author, and showed that basically, suggests that hemodiafiltration is better, and this correlates with improved blood pressure control and clearances on hemodiafiltration. Now, there's this another study from 3H using 24-hour blood pressure monitoring, and you can see here the differences in blood pressure control and maintaining blood pressure in hemodialysis versus hemodiafiltration, okay? And clearly, those on hemodiafiltration 24-hour map was just very nicely controlled. So possible mechanism for better hemodynamic stability and blood pressure, increased convection, which might lead to a little bit more sodium removal, less intradialytical weight gain, and better blood pressure, more efficient removal of middle molecules, allowing better and more lasting hemodynamic control, maybe improved some kind of inflammation, less arterial stiffness, and dialysis is naturally cooled, which itself may reduce the rate of dialytical hypotension compared with standard dialysis. frequent dialysis and fluid overload, of course, this is what we do, right? So this is our 3 days per day, week, and you can we already saw at the beginning few studies showing what's happening with blood pressure and weight fluctuation, right? Of course, 5 days per week is better, we think, right? And that's just more physiological, right? Decreased fluid overload will allow for gentle ultrafiltration resulting in better blood pressure control, better cardiovascular health, and improved patient well-being. I'm going to back to a study that was done by Michelle Fischbach more than 20 years ago, right? 5 oligonucleotide dialysis patients, LVH and poor cardiac function on these patients, okay? Decreased shortened fraction and reduced therapeutic compliance. So what he did, he looked at the standard hemodiafiltration 4 hours for 3 times a week and change it for 3 hours for 6 times per week. And here's the result, right? Blood pressure is better. You can see here shortening fraction is better, right? And LV structure is better, right? Interventricular septal increase, and also diastolic function is better, okay? So it's nice. So this is our study. What we did, we look at the short, frequent 5 times per week center hemodialysis versus 3-day per week treatment. And this was a randomized crossover pilot trial. Again, this is from PNRC. And the reason why we did it, because the previous study just didn't control for total time of dialysis. So we tried to control, okay, everybody will get 12 hours of dialysis per week, but some of them will have it through 3 times per week, 4 times, and another 5 by 2.5 hours. Okay, so we control for basically for time here. And that's what we see, right? Number of days with or without fluid overload, which define more than 4% of weight gain. In the red, basically those who had more fluid overload, 4%, and you can see that on the left, 3 times, on the right is 5 times, definitely we have better fluid control, and that was translated to better blood pressure and less use of antihypertensive medication. Other consideration for controlling of hypertension is blood pressure medication. Okay, again, this is our old study from PNRC, and not surprising that we are using ACE inhibitors and calcium channel blocker more than any other medications. That's our first line of therapy. But also remember that blood pressure medication can be removed by hemodialysis, right? ACE inhibitors largely removed, ramipril 20-30%, and enalapril 35-50%, except fasenopril. Okay, ARBs and calcium channel blockers are not dialysable. Okay, so beta blockers like atenolol, metoprolol are highly dialysable. Okay, propranolol or labetalol and carvedilol are not dialysable. So I think when you start patient on blood pressure medication, always think about which one is dialysable and which are not dialysable. Optimal timing also should be in consideration, but it's still debating because KDOQI 2005 said at night is preferable. KDOQI 20, it should be individualized, whatever it means. And also very interesting, discontinuation prior to dialysis session is not advisable, okay, because the effect is unknown. So again, I'm going back to the same study from KI report, and they look at what drug is better. In their study, 62% observation had antihypertensive medication, approximately 2 blood pressure medications. Again, calcium channel blocker, ACE inhibitors were used a lot, but beta blocker 45% and diuretics in 70%. So remember, this is hemodialysis patient. They still use diuretics, which is quite unusual, right? But what they looked and saw that, and did multiple regression analysis and use of beta blockers was associated with better blood pressure control than other classes of antihypertensive medication. And also, among those who were prescribed diuretic, urine output was twofold higher compared to those who were not. Of course, all these patients had some urine output, so that's why they were prescribed diuretic. For those who are anuric, we're probably not going to use it, but it's very interesting. These data are quite novel, and we have to rethink, what to do with diuretic, what to do with beta blockers. Are we reinventing the wheel? And I can show you this is data from early age of hemodialysis treatments, right? 1969. Look at the blood pressure control. 95% of patients had blood pressure control. Of course, it's adult study, not pediatric study, right? But this is what happens over our progress in treatment of patients on hemodialysis, or I would say progress, right? So, first of all, from approximately 12 hours of dialysis session, which is definitely not practical, we went to at least 3.5, 4 hours. And you can see here, sodium diet. We now use a lot of processed foods, right? Sodium is up. Now, and 80%, we also use a lot of sodium remodeling, and we're not using, some centers use, for example, 140, 142 in hemodialysis for sodium, so that's probably too much. And again, that all led to the prevalence of hypertension from 10% to 80%. So I don't know if we're doing a good job, but again, you saw that we, as pediatricians and pediatric nephrologists, have any improvement over the last 20 years in management of hypertension on hemodialysis. I didn't put much here on this talk on the peritoneal dialysis because I think blood pressure may be a little bit better control, but still not optimal. Sorry. Summary, uncontrolled hypertension is frequent in children on dialysis. Accurate assessment of dry weight is initial and critical step. Avoiding fluid and salt overload is the most important step in controlling hypertension, and controlling hypertension is critical in preventing cardiovascular disease, the most common cause of death in children on maintenance dialysis. Thank you very much.
Summary, I'd like to make a question to Dr. Yes.
Thank you, Mark. We all agreed that volume is our, so it's most important.
Thanks for having me here. It's working, thank you. I also want to thank the organizing committee for inviting me to this beautiful conference and this beautiful country. It's my first time also here. So for the next 10-15 minutes, we'll be talking about an ignored topic, which is MAST hypertension. We've been talking about diastolic hypertension, systolic hypertension. MAST hypertension is getting a bit left out, so we'll talk about MAST hypertension. And I'll tell you the most commonly used definitions of MAST hypertension, how common is it in pediatric population, how does it affect adults as well as children, and then there is hardly any management data specific to MAST hypertension in children, but I'll talk about some novel trials that have been published in the adult population in the last few months. All right, so I'll go through it quickly. We have been talking about since whole morning that how do we measure blood pressure in children. Clinic blood pressures are easily done. They are very quick and easy, but they also have biases. It can lead to white coat effect. So most of us resort to home blood pressure monitoring, or ABPM, as an out-of-office blood pressure checking. At least in adults, home blood pressure is very well established. It has been shown to be associated with cardiovascular outcomes. But in pediatric, we don't have it well established. We do not have validated machines, as we heard this morning. And also, we do not have, it's actually quite less sensitive also when you compare to ABPM. So for that reason, none of the pediatric guidelines actually recommend home blood pressure monitoring for diagnosis management. So we all resort to to ABPM. It has been very well established in children, can diagnose white coat and masked hypertension, but it has also limitations. We heard about normative data being not great, and also, machines are quite expensive. They are not readily available in most part of the world. But nonetheless, based on all these three types of blood pressure monitoring, there are 4 phenotypes of high blood pressure, and I will just focus on masked hypertension for the purpose of this talk. In this case, the office blood pressure is normal, but if you look at the out-of-office blood pressure, either home or ABPM, it's high, and that's how we diagnose masked hypertension. All right, so this was also discussed this morning. I'll go through it quickly, that there are 2 specific guidelines to diagnose masked hypertension based on ABPM. This is the American Heart Association 2022 guidelines. A bunch of changes were done compared to the previous one. They removed the blood pressure load. They also introduced absolute blood pressure cutoffs at more than children who are 13 years and older. And you can see that it is now kind of aligns with the European Society of Hypertension guidelines, in the sense that they also do not have blood pressure load. But there is a slight difference in the sense that ESH guidelines have absolute blood pressure cutoffs at age of 16 years and older, and their blood pressure cutoff is slightly higher compared to the American Heart Association guidelines. So we already discussed that, so I'll just skip this part. And the main question that comes is, how common is masked hypertension in our pediatric population? And there have been multiple studies done in the last 10-20 years to understand the prevalence of masked hypertension in children with different comorbid conditions. So we thought we will summarize all of this evidence into a systematic review, and we published that 2 years back in Hypertension, in which we included all studies done in English language until 2023. We included all types of studies except case series and case reports, but the mean age of study population was less than 18 years, so it means that there were few studies that had children, that had young adults, but the mean age of the entire population had to be less than 18. All participants needed to have a 24-hour ABPM done, and we included studies with at least one evidence of subclinical cardiovascular marker. So the primary outcome of this review was to understand the prevalence of masked hypertension, either using the American guidelines or the European Society of Hypertension guidelines. As a secondary outcome, we wanted to understand the risk of subclinical cardiovascular outcomes in children with masked hypertension compared to those with normal blood pressure. And we basically used 3 measures of subclinical cardiovascular outcomes, which are listed here. So left ventricular hypertrophy, increased pulse rate velocity, and increased CIMT. All right, so this is the main forest plot that shows the prevalence of masked hypertension. On the extreme left-hand column, you'll see, the population of interest, and the extreme right-hand column, you'll see the prevalence of masked hypertension. Before we talk about the children with comorbid condition, I just want to highlight the first top row here, which is the general pediatric population, and there was no data until now to suggest what's the prevalence of masked hypertension in general pediatric population, and we were able to show that it's around 10%, which is close to like the adult data, and we don't know actually why this general pediatric population has masked hypertension. Maybe these were children who had obesity and they were not reported, or these were children who had a family history of hypertension. So we could not go into more detail about how do we explain this 10% risk, but it has been reported also in some previous studies. All right, so if you look at the other children with comorbid conditions, so like coarctation, obesity, sickle cell disease, any kind of transplant, either solid organ or stem cell, and we stratified CKD into different types. You can see that their prevalence was quite high, and at the bottom you will see the overall pooled prevalence was around 18% across the pediatric population, including all comorbid conditions. But you can also imagine that there was a very high heterogeneity as seen by the I-square, which was 98%. And the main reason was we just pooled in all comorbid conditions into one kind of forest plot. And also, there were different definitions on how they define masked hypertension. So that is just the overall pooled prevalence. As a next step, we also wanted to understand how does the risk of mask hypertension compare to the general population. So this is again from the systematic review. You can see that children with coarctation, obesity, sickle cell disease, any form of transplant, and CKD overall had a very high rate ratios of masked hypertension compared to normotensive children, compared to general population. But more interestingly, we found that children who had sleep apnea did not have a higher risk, which was, I think there was some discussion on this topic yesterday. All right, at the same time that we published our review, Dr. Stella Statui's group also published their systematic review on masked hypertension, but they only focused on children with CKD, and they had a total of around 1,100 children, including 10 studies from CKD stage 2 stage 5. The mean age was around 14 years. They also found quite a high prevalence of masked hypertension, ranging from 22% in the dialysis population to almost 29% post-kidney transplantation. So you can see a very high burden of masked hypertension in all of these children with comorbid conditions. All right, but these comorbid conditions are not the only risk factors or predictors of masked hypertension. There are studies that have shown that children whose blood pressure is in the elevated BP range, so they are not yet hypertensive, they are between 90th to 95th centile, that's also an independent risk factor for masked hypertension in both healthy children as well as those children with CKD. There are some other studies that have shown that if there's a family history of hypertension, male gender, and high sodium intake also is a predictor for masked hypertension. And then finally, there is one very interesting study published on the CKID group, in which they had children with chronic kidney disease who had done their ABPM, and they used machine learning models, and they found that those children with CKD who had an office systolic blood pressure of less than 20th centile or an office diastolic BP of less than 80th centile, they had a very low risk of having masked hypertension. So you can basically skip doing ABPM in those children, but if the BP is higher than that number, you got to do the ABPM to confirm masked hypertension. All right, so with this background, let's try to understand how masked hypertension affects our children. I'll first show you adult data because there's lots of adult data out there. But one of the questions which is also asked is how often does masked hypertension persist, and how often does it actually progress to sustained hypertension? So we'll talk about that. And then how does it affect target organ damage in both children as well as in adults? All right, so this is some adult data. On the left-hand side, you'll see a meta-analysis published in the adult population. So what they did was they included all studies where adults either had treated or untreated masked hypertension. And you can see at the bottom that the risk of having a fatal or non-fatal cardiovascular or cerebrovascular event in those adults who had masked hypertension was 2 times higher compared to those who had normal blood pressure. On the right is a cross-sectional data. This is from Japan. They had adults more than 40 years of age, around 2,900 of them, and they wanted to understand the association between masked hypertension and albuminuria. So on the y-axis, you will see the urine albumin creatinine ratio. On the x-axis, you see the different categories of hypertension. And they found that those adults who had masked hypertension had a higher albumin creatinine ratio compared to those who had normal blood pressure. Interestingly, they did not find any differences in their eGFR based on the blood pressure category. All right, what about pediatric data? So, as I said before, we always ask this question, and even parents ask the question, what will happen to my child with masked hypertension? Would they continue to have that? Would they progress to sustained hypertension? So this answer came from Dr. Ampal-Latve's group. This is an old study more than 20 years back, in which they had around 600 youth between 6 to 18 years of age, and around approximately 45 of them had masked hypertension. And what they did was they actually followed approximately 34 of them over a period of 3 years. And what they found was that 3 of those 34 actually progressed to sustained hypertension. And more interestingly, approximately a third of these children had masked hypertension even after 3 years of follow-up. And what they also showed that those children who had either masked hypertension or sustained hypertension had a higher LVMI compared to those children with normal blood pressure. All right, the same group of authors, published another study. This was a longer term follow-up. So the previous follow-up was only 3 years. This was an 8 years follow-up of the same cohort. And the main question in this study was to understand, what is the long-term effect of having masked hypertension? How often do they progress to sustained hypertension? So two key findings came from this study. Number one was, if boys had masked hypertension in this cohort, they had a much higher risk of progression to sustained hypertension, and there was some suggestion of having effect of puberty or growth pattern in this area. And what they also showed was those adults who had masked hypertension, those children who had masked hypertension at baseline had a much higher risk of actually converting to sustained hypertension over a median of 8 years of follow-up. So again, very interesting findings to see how the ABPM phenotype actually changes over time in these children. Some adult data. So this is a Canadian study, slightly older one again, around 1,600 adults, 232 had masked hypertension, and they followed this cohort for a period of 3 and 5 years, and they showed that after 3 years of follow-up, approximately 40% of them actually persisted to have masked hypertension, but more interestingly, a quarter of them actually progressed to sustained hypertension. So again, you can see similar data in the adult population. All right. So what happens to target organ damage with these children? So we have been hearing all this morning that blood pressure in childhood can lead to adverse cardiac changes, vascular changes. Dr. Baker-Smith nicely talked about all those changes, and we can study these changes through these markers of target organ damage. And studies have shown that if you don't treat these children in time or identify these children in time, they can lead to future cardiovascular events. But that is all very well known in sustained hypertension children and adults. What about masked hypertension? What happens when you have these children with masked hypertension and over the long period of time? So this is going back to a systematic review in which we try to understand the effect of target organ damage in children with masked hypertension compared to normotensive children. This is the forest plot that shows the effect on LVMI. So you can see on the two columns, it shows the masked hypertension children, and then you see the normotensive children, and this is the main difference. And we were able to show that children who had masked hypertension had a much higher LVMI compared to children with normal blood pressure. There was again moderate heterogeneity in the data, and the reason was, which Dr. Baker-Smith highlighted, was the way the LVMI was calculated was quite different in all these studies. Some study had the older definitions and the newer definitions. That's what accounted for the differences in the LVMI as well as in the I-square being high. What about LVM? So again, we showed that children who had masked hypertension had a 2.5 times higher odds of having left ventricular hypertrophy. Again, the I-square was a bit low, which is good, meaning there was less heterogeneity in the data, but still these children are at a higher risk for left ventricular hypertrophy. Going back to Stella study, so again, which I showed you earlier, in this systematic review, they only focused on children with CKD and who had masked hypertension, and they also showed that children with CKD and masked hypertension had a very high prevalence of LVH and LVMI, compared to other children. What about data on other target organ damage markers? So again, in a systematic review, we only had 3 studies that studied pulse wave velocity, but still we were able to show a significantly high pulse wave velocity in children with masked hypertension compared to normal blood pressure. Unfortunately, we only had 1 study from Stella's group, which had done CMD in this population, and they did not show any statistical significance. All right. So what about kidney outcomes? And again, there is very less data when it comes to kidney outcomes in children with masked hypertension. I only could find this 1 study, and also in pediatric kidney transplant patients. So they had 77 children with kidney transplant, a quarter had masked hypertension. And if you see this left table, these are those children who had no blood pressure treatment, and half of them had almost normal blood pressure, and the 6 of them had masked hypertension. And they found that no matter what GFR definition you use, children who had masked hypertension had a significantly low eGFR compared to those who had normal blood pressure. And when they treated those children, but if the masked hypertension was still uncontrolled, they still showed a lower GFR in this cohort of children. Again, this is a cross-sectional study. We can't make any more inferences from it, but I think the data is quite clear that mass hypertension in children, regardless of their cause, is associated with significant target organ damage markers. How do we treat them? Unfortunately, there is no guidelines on how to treat mass hypertension. None of the pediatric hypertension guidelines have specific guidelines on mass hypertension. So we just start with our lifestyle changes. We ask them to improve physical activity, eat less salt, sleep time to be improved, diet, and we do all of these things. But again, there is very low evidence, does it even work or not, especially in mass hypertension children. And if there are certain children that we have to start them on anti-hypertensive drug treatment, and those are those children with mass hypertension who have some form of target organ damage, secondary hypertension, symptomatic high blood pressure, or if the mass hypertension is persisting. Again, these are not evidence-based guidelines, these are just expert opinions and what we just follow in our clinical practice. All right, but adults have gone a step ahead and they have just published this very interesting trial called as anti-mass trial. This was published in E-Lancet, E-Clinical Medicine in Lancet Journal. So this was a multi-centric, double-blinded, placebo-controlled trial to understand the effect of anti-hypertensive treatment for target organ protection in adults with mass hypertension. So they had a total of around, I think, 200 adults between 30 to 70 years of age who had mass hypertension based on ABPM, and they had one sign of target organ damage. Half of them were treated with elisartan and the other half with placebo, and you can see on the right figure that those who were treated with the drug were actually able to improve their blood pressure, which also seen in this table here. But more importantly, they showed that those who were treated with medication, they actually had a much better improvement in their target organ damage. Approximately half of them improved compared to only 1/3 in the placebo group. So this is the first trial actually to show that if you treat mass hypertension in adult population, it can improve your blood pressure as well as signs of target organ damage. All right, so just to summarize, I think I should be able to convince you that children have mass hypertension. It's important to screen them, and especially those children who have these comorbid conditions which are listed here, especially CKD, diabetes, obesity, and transplantation. Coagulation is very important. And also, now what we don't know is what do we do with healthy children? Should we screen them? Should we not? Again, not evidence-based, but some studies have shown that if there is high normal blood pressure, it's good to screen them, or those who have a positive family history of hypertension. There is now strong data to show that mass hypertension is associated with subclinical cardiovascular outcomes, but I want to highlight two important knowledge gaps here. The first one is most of the some part of the world they don't have ABPM, and I think we need to develop standardized home blood pressure protocols to diagnose mass hypertension in those children, and we need more pediatric studies to understand how best we treat mass hypertension in our population. So with that, I'll end. I really want to thank my...
And to describe the association between increased left ventricular mass and cardiovascular related events, mainly in adults. Although some of that data you've heard this morning, we collect in children, and we've been able to sort of prospectively follow forward and identify the associations with risk in children with events in adulthood. And then we're going to describe the relationship between blood pressure and target organ damage in children and adolescents, and the thresholds associated with the development of target organ damage. So let's start with some definitions. I did put US definitions, but elevated blood pressure, what that is in terms of the absolute number, or actually percentiles, if the child is less than 13. White coat hypertension, having blood pressure that's high in the office, but normal out of the office. Mass hypertension being the opposite. And then target organ damage, and again, focusing on the heart. So concentric remodeling, concentric hypertrophy, eccentric hypertrophy, and decreased ventricular function. So the heart is a magnificent organ, speaking as a cardiologist. There are adaptive and maladaptive changes that can occur, though, to the left ventricular mass. And an example of adaptive changes are the changes that occur for an athletic heart. Maybe there's increase in the mass of the heart related to the type of activity that the child participates in, and also maladaptive changes that can occur as well, where there's left ventricular hypertrophy, say secondary to hypertension, or obesity, or secondary to some sort of vascular abnormality. So this is an example of a child that I saw 11 months of age. As you can see, I'm not expecting anybody to read an echo here, but the left upper chamber is dilated, the left atrium, the left ventricle is dilated. It's almost impeding in on the right ventricle, and it's big and boggy, and it doesn't squeeze very well. And this child had mid-aortic syndrome. So after repair of the mid-aortic syndrome, I can see that the function is nice and much more robust. So this is an example of maladaptive in the setting of mid-aortic syndrome and then recovery of function after repair. So there are stages of target organ damage. I've broken them up this way. There's increased relative thickness, relative wall thickness that can occur in the setting of, say, increased internal diameter relative to increased volume, and that's to preserve wall stress. There can be increased left ventricular mass, and then increased relative wall thickness plus the increased left ventricular mass is what we call concentric hypertrophy, and that's actually a precursor to heart failure with poor systolic function, or heart with systolic function that's EF that's less than 55%, or diastolic dysfunction. We say that's heart failure with preserved ejection fraction, or HFpEF. And there's many different reasons that this can occur. Obviously, we're talking about hypertension, but there can be overlapping conditions, and I'll talk a little bit about the overlap between heart and kidney and obesity and metabolic syndrome and how that impacts target organ damage. Now, I do want us to understand, I mean, we talk a lot about target organ damage in this space, but I think the devil's in the details, understanding how is that measurement made, and there are differences. And these next two slides are going to show you just how the measurements are made and how you can pay attention to it when you read some of the papers that you're reviewing. Mostly what you'll see is that we've used the Devereux equation, which is basically, this is a cross-section we call parasternal long axis of the heart. It's measuring the left ventricle. And then on the right, you see it looks more like a donut, and that's a parasternal short axis. And we're going to measure the thickness of the walls of the heart and the internal diameter. Now, the equation that we're using at Devereux, any measurement that you're making, you're plugging it into an equation, and then you're cubing it, right? So if I have a little bit of error, I'm cubing that error, right? So it's not as precise as some other ways of calculating left ventricular mass, but it is what we used to do, and it is where many of the studies have reported left ventricular hypertrophy. More recently, the echocardiographers and the societies for echocardiography have revised how they measure mass, and that's the area length method. So basically you take the length of the ventricle and you take the volume and you calculate the left ventricular mass. Now, these numbers don't agree 100%. So if I measure the size of the ventricle along the parasternal long axis view, that may be very different than the parasternal short axis view, but it's certainly very different than if I use the 5-6 area length method. And that's important to consider, okay? Because when you get your echo reports or you get your feedback from the cardiologist, they're going to give you a left ventricular mass. If you're trying to equate that to what we see in publications, again, it may be different. So what we've done in our lab is we actually have maintained the old way. So we reported two ways. We report the 5-6 area length method, but then we also take the short axis, determine the posterior wall dimension, determine the internal dimension, calculate the relative wall thickness. And if it's less than 0.42, which is the number we use in the clinical practice guidelines, it's then normal. Concentric remodeling is when you have a relative wall thickness that's greater than 0.42 and normal left ventricular mass, and I'll describe what we've just defined as normal versus not. And then eccentric hypertrophy is the opposite, where you have normal relative wall thickness but increased mass, and then concentric hypertrophy is where there's both. And that, as I mentioned to you, is more of a precursor of what we see for predicting heart failure and decreased function with, preserved function with decreased diastolic function. Okay, so this is a nice 2x2. This makes it easy. So I put it in descriptive words, but I'll put it in a 2x2 for those of you who like it in that format. And this is what we use, okay? So, and again, this is what was included in the 2017 clinical practice guidelines, with the exception that we use an absolute cutoff for left ventricular mass that's indexed to the height to the 2.7. For those greater than or equal to 8, I'll tell you why. And for those who are less than 8, we use an index to the body surface area. And this is just some pictures that show you what that looks like. Okay. So why does it matter? So this is adult information. I would say doing this long enough, you see kids on a full spectrum of target organ damage. I've seen the kids with, unfortunately, the decreased function at a younger age with hypertrophy, but typically that happens much later. So what's the thought? The thought is that this increased mass is related to some changes in the myocardial perfusion, decrease in ischemia, which then can be a setup for arrhythmias, and this idea of sudden death related to changes in the mass of the heart. Now, whether it's related to that or related to coronary artery disease and the whole progression of acquired heart disease, that's another possibility, but these are some suggested explanations for why increased LV mass is associated with earlier cardiovascular events and higher risk or higher rates of cardiovascular events in adulthood. Left ventricular mass does vary by sex, so with males in the red and women in the blue, you can see that the mass does increase more in males, probably maybe related to a number of factors, maybe testosterone, but certainly there's a difference. And then this is an interesting graph, and this helps to kind of understand why we sort of made this cutoff around 8. When you look at changes in left ventricular mass over time, you'll see that the curve, the slope of the curve, you can kind of put a sled on the first part and have a good time sliding down, and then it sort of levels off right around 9. And so that is where we started to think about using an index mass to the height to the 2.7, and there's a lot of variability in left ventricular mass before 9 years of age. So it's some work that was done previously. So how do we index the mass? Because there is sort of this discrepancy in raw measurement as you go over time. You can see that in the left picture. If we just index by the height of the individual, we don't resolve that difference. And if we index by BSA later as a child ages, we also don't resolve the difference in left ventricular mass. So what was found, if you index by height to the 2.7, you do have some leveling of that mass and accounting for changes that occur with age. So this is data from the MESA study, which basically looked at the relationship between either quartiles of left ventricular mass on the left and coronary heart disease, or percentiles of blood pressure on the right. And for the highest quartile, left ventricular mass index was associated with the greatest chance of coronary heart disease events, and similarly, the highest percentile of left ventricular mass associated with congestive heart failure later in life. And this is additional data looking at the relationship between hypertension and LVH and the experience of a cardiovascular event. Here you'll notice they did describe the LV mass index by body surface area, so different than what I described to you earlier. But the point here is that there's a 3.2 times greater risk of coronary event in the presence of increased left ventricular mass versus not. And then when they use the actual cutoff of 51 grams per meter to the 2.7, those with elevated left ventricular mass index had the greater probability of events or lower probability of event-free survival, in which you see here. So the best cut point to predict cardiovascular events is a left ventricular mass index of greater than 51 grams per meter to the 2.7, and it predicts 3.3 times or so greater risk for a cardiovascular event. So if we use 51 as our cutoff for kids, okay, so this is 0 to 19 years of age on the x-axis for both boys and girls, and it does left ventricular mass, you'll see that that 51 far exceeds the 99th or even the 90th or 95th percentile for both males and females. So there's definitely room to describe significant increased mass in terms of absolute number for males and females, with values for females maybe being a little bit lower. In the clinical practice guideline, again in 2017, we did define LVH as having left ventricular mass greater than 51 grams per meter to the 2.7, and again greater than 115 index for body surface area for boys less than 8, and for greater than 95 grams per body surface area for girls less than 8. Concentric geometry was, or concentric remodeling, was having an increased relative wall thickness. I showed you how that performed. And then obviously having a relative wall thickness that's exceeding, or wall thickness itself exceeding 1.4 was considered abnormal. And we defined decreased LV function as less than 53%. So what is the blood pressure threshold that then leads to left ventricular hypertrophy? And I think this is an important point because obviously we've defined elevated blood pressure and hypertension at these certain cutoffs, but what we're really trying to do is improve longevity, improve long-term heart health, and reduce events. And so we should know what that threshold is for reducing the presence of left ventricular hypertrophy and for reducing the incidence of cardiovascular events. But to do that is to understand that hypertension is not the only factor associated with increased left ventricular mass. Obesity is another factor independent of hypertension that can be associated. And there's some pathophysiologic reasons for that. I've just put a little graph here highlighting some of that. This is from the Bogalusa heart study. But there's increased cardiac workload and changes in ventricular geometry that can occur in the setting of both obesity and elevated blood pressure. So the previous speaker talked about ambulatory blood pressure monitoring. We like using ambulatory blood pressure monitoring, particularly for confirmation. I think there was a question in the audience about reproducibility of measurements of patients not coming back. I take care of a high deprivation population, very hard for people to get off from work. We use ambulatory blood pressure monitoring to confirm the diagnosis after one manual blood pressure at or above threshold, and this is in the primary care setting. But what about the relationship between ambulatory blood pressure and left ventricular mass? And so this is work from Elaine Urbina, Dr. Urbina, her group looking at daytime systolic blood pressure going to 80 ppm on the x-axis and left ventricular mass on the y. You can see that with these dots, you can see an increase in left ventricular mass, not quite at the threshold described to you, but nevertheless increasing beginning around 120 millimeters of mercury, but even less than that. So my esteemed colleague, Dr. Shaklani, is here in the audience. His group looked at the risk of target organ damage in children with primary ambulatory hypertension and performed a systematic review and meta-analysis, and this included 38 studies, including studies from Poland and the US, and even after adjusting for body mass index, they found if you look at different types of target organ damage, but primarily the focus of this talk is left ventricular hypertrophy, there was a significantly greater odds of left ventricular hypertrophy and the setting of ambulatory hypertension as determined using the ABPM. So this was a great study, but the one I think that most people know is the Shippleboy, and several of the PIs for Shippleboy are here. So Shippleboy was a study of high blood pressure in pediatrics, adult hypertension onset and use. And this was a study that preceded its time, and it was a cross-sectional study of otherwise healthy youth, 11 to 18 years of age, with blood pressure ranges 75th to 95th percentile. And they were interested in looking at the relationship between casual blood pressure, ABPM, and target organ damage. They did use the Deborah equation to define left ventricular hypertrophy, sorry for that. There were about 397 patients, a mean age of 15 years, largely white and male, with a blood pressure distribution that varied, and some did have obesity. There were a number of target organ assessments that were performed, including echo, but also pulse wave velocity, and there were cognitive tests that were performed as well. And they used a defined cutoff of 38.6 grams per meter to the 2.7 or 95th percentile. And then there were some other tests that were performed as well. So this is a slide that was provided to me courtesy of Dr. Urbina, looking at the relationship between the different categories. So if they had normal versus white coat versus mass hypertension versus sustained hypertension. This is predating the 2022 update to ABPM with left ventricular mass index. You can see the relationship between these categories and index left ventricular mass. And then in terms of the criteria that we use, I mentioned to you that was preceding the 2022 update, but previously we used percentiles for characterizing ABPM, pediatric percentiles, and then there was an adult cut point. If we reallocated those patients according to the adult cut point, what you see here is that there was a better sort of predictor of increased mass, certainly related to hypertension, with cut points, the adult cut points, than with the pediatric percentiles. So it made sense to make that transition, especially for kids 13 years of age and above, to go from these percentile cut points to actually using set cut points which we published with the 2022 update. And then other groups have studied the reclassification of blood pressure according to that reset, if you would, and how we define hypertension according to ABPM, with many of those who had pre-hypertension reclassified as having hypertension and primarily isolated nocturnal hypertension with the update. So I want to just pause here and just introduce one new framework that you may not be familiar with. This is something that we published last year coming from the American Heart Association. Typically, we think of risk factors for cardiovascular disease as isolated. We have obesity, we have hypertension, we have lipids, right? But what we did here is that we looked at the intersection, having more than one of these conditions, and was that associated with greater cardiovascular disease and events later in life? And it is. And so I had the honor of being one of the two pediatricians on this statement. But what it does is it takes the isolated events, or isolated factors, if you would, so the health factors associated with the AHA life essential aids, blood pressure, cholesterol, blood sugar, BMI, and then health behaviors, and puts that into this context. So there's different stages. It begins with the absence of any risk factors to stage 0, and then it goes through dysfunctional adiposity. So you go from having 0 to stage 1, which is overweight or obese, having obesity, to stage 2, which is having metabolic factors, any of them. So triglycerides that are high, hypertension, metabolic disease, or chronic kidney disease. And then it keeps accelerating. So this is, again, I was working with mostly adults, so we're looking at subclinical atherosclerotic disease, including coronary artery calcium scores, or CAC scores, and then actual events. And so obviously kids, unless they have FH or some severe forms of something, they typically don't have the stage 3 or stage 4A, 4B. But the important point here is the overlap, having multiple cardiovascular risk factors associated with greater risk for events later in life. So I bring that up because one of the more recent studies from the Shipahoy data looked at the relationship between left ventricular mass and the number of cardiovascular risk factors. So defined a little differently, they did include things like uric acid, CRP, HOMA, but the idea is that having more than 2, right, you have increased mass. So I think it's important to recognize that it's the entire picture, not just the hypertension, that can also be important for kids as well. And then this is a different question, this is a different study. They looked at the relationship between 3 categories of blood pressure, both clinic blood pressure and then ABPM, and they had the low, mid, and high groups, and then looked at the relationship between those groups and the number of target organ damage. So LV mass, systolic dysfunction, diastolic dysfunction, pulse wave velocity. And so the higher the blood pressure in the office, the more the top portions of that that bar, if you would, the more target organ disease markers that you had. And similarly with ambulatory red blood pressure monitoring was the same. So again, this idea that the number of factors, the severity of the factors all matter. And then here they looked at the different categories. So normotensive and NT, white coat hypertension, mass hypertension, and sustained hypertension, again, relationships to the number of events. Okay, so almost done. So treating hypertension and what's the relationship with target organ damage. We all know that we start with lifestyle, right? Very important. Most kids do not get the lifestyle, at least in the US, that they're supposed to get, only about 20%. Get the diet that they're supposed to get, get the amount of physical activity that they're supposed to get, and then obviously there's medications that we can use. So this slide also provides me a courtesy of Dr. Urbina, but this looks at the relationship between baseline and then after 12 months of treatment for hypertension, all treatments included, and there was a shift in the prevalence of eccentric hypertrophy, so a decrease in eccentric hypertrophy with treatment. So certainly there can be benefit in terms of target organ damage if it's properly controlled and managed. All right, so in conclusion, increased left ventricular mass can present in childhood, can be rare, but does occur. Increased mass is a predictor of later cardiovascular events, as I've shown you. Increased left ventricular mass is not only associated with hypertension, but also with obesity and other cardiometabolic risk factors. So the more risk factors you have, maybe the greater the risk. And then treatment can be helpful in reducing left ventricular mass. And with that, I thank you for your time. I'll take any questions and join.
Lots of presentations about this. And then as a unit, so then the difference is it came, as people have said, the nighttime we're able to, and daytime from 13 years onwards, we're able to do daytime of 130/80 and then nighttime 110/65. So as a unit, then we wanted to standardise our guidelines. So we wanted to decide which guidelines would we use. Would we, because we wanted to update it, because we were using 2012, so we wanted to look at the 2016 European guidelines and the 2022 guidelines. So we did an audit in our hospital. So we did it, we took recordings for 6 months, March 2023 to September 2023, and we did the BP load assess using the 3 guidelines, and we did the 24-hour ambulatory blood pressure on patients, but we wanted 50 successful readings, and we compared them with the sex, age, height, and specific ABPM data. So we had 72 patients in our study, or our audit, and 17 patients were insufficient readings, so we did the same. We did if they had successful readings of 40 and above. So we analysed 55, and the median age was 14 years, and the range was 7 to 18 years. So we had 59 readings, so we were above the 40, and there was no sex predisposition. So the commonest cause, I forgot to say I work in the nephrology unit, I don't know if I said that. So they were the congenital abnormalities of kidney and urinary tract, and other diseases with cystic kidney disease, vasculitis, and renovascular, and miscellaneous. It was 27. So this was our results. So the 2012, so you can see the daytime systolic blood pressure in red for the 2012, 2016 European and 2022 American guidelines have. And then the daytime dark blue is pretty much the same across all 3. And then the lilac pink nighttime systolic. There is a bit of a difference, but we think that was because of the 110 guidelines we followed for the American Association, and then the diastolic is the same across all 3 guidelines. And then if you go over to let's see if I can use my light, the hypertension, so they were 55 were the American 2012, 2016 was pretty much the same, and then it was slightly higher for the 2022 American Health Association. So then our results showed 52% of the patients were hypertensive, and with the 2012 and 2016 guidelines, and 60% were hypertensive in our 2022 guidelines. So the difference was statistically non-significant. So our conclusion did not fluctuate between the guidelines used for the report. It was not helpful for diagnosis as per newer guidelines, and the ABPM recommended in all pediatric patients with elevated BP. So we had a consensus that we would go with the 2022 guidelines. And the reason being is our numbers have gone up dramatically for ABPM. So I think we were started back in 2010 with numbers of 50. We're over 200 readings. So it makes it easier for us as a department to do a cutoff from the age of 13 upwards. The second thing is we have a lot more young people being referred to us now because of obesity, and we've quite complex conditions, so we do have regular BP updates to see, we make changes to their treatment, and then we want to recheck if they're on the correct treatment. So by having the American Heart Association guidelines, it makes it more simplified for us. Thank you.
We have time for one very short question. If not, we may.
On ABPM, how to assure the quality of ABPM?
Okay. Thank you, Thomas. I try to keep time that everyone is having enough time for discussion with the next presentation and also for having a coffee break. So how to assure quality in ABPM? There are many factors influencing blood pressure in children. It's how agitated the child is, the number of measurements we are performing, the position, whether it's supine or sitting, the measurement technique, the season of the year, also the ambient temperature in your examination room, and of course, the time of the day plays a major role. When we are looking at this blood pressure curve over 24 hours, it's MAP, it's clearly showing that we have a circadian blood pressure variability. And that is, we have a low blood pressure at night, and during daytime with also activity, we have varying higher blood pressure levels, and you can also see that one single measurement, even if you have 3 in a row, will never tell you the whole story. So blood pressure variability is driven by an internal oscillator clock, which is a little synchronized by light, social factors, and chemical and physical factors, and results in our activity level, blood pressure, heart rate, and temperature variability over 24 hours, and also hormone secretion. And in addition, it's modified by our behavior, if we're drinking, smoking, how good is our sleep, emotional state, mental and physical activity, sympathetic nervous system, RAS, and our salt sensitivity. So, because one measurement alone will never give you the diagnosis of hypertension, it is recommended to do 24-hour blood pressure monitoring. At least at this process of diagnosis, you should confirm hypertension before starting antihypertensive drug treatment to exclude white coat hypertension. In patients with target organ damage despite normal office BP, to exclude masked hypertension. In patients with diabetes, chronic kidney disease, patient after solid organ transplantation, patients with obesity, and patients with inadequate response to treadmill tests. And if there's a discrepancy between office BP and that what the patients are reporting from home BP measurements. It's also helpful during antihypertensive drug treatment for the evaluation of apparent drug-resistant hypertension, assessment of blood pressure control in children with target organ damage, and if patients report hypotension. It's helpful for clinical trials. I will show a slide later on this topic. And it's also helpful for other clinical conditions as autonomic dysfunction or suspicion of catecholamine secreting tumors. So, how to measure correctly? So, the first topic is select an ABPM device that is suitable for the use in children. So, only validated oscillometric or oscillatory ABPM devices should be used. I think from those available on the market, they are all oscillometric now. And also an appropriate cuff size should be used according to the recommendations also for office BP. And please also do not mix and match cuffs from other producers. Second, a standardized approach to obtain EBPM studies should be applied. Place the monitor in an office setting to enable checks for accuracy. The monitor should be applied to the non-dominant arm unless there are contraindications, for example, dialysis fistula. And you should measure blood pressure on both arms before starting the study if there's a difference of more than 5 millimeters of mercury placed the cuff on the arm with the higher BP. In patients after repaired aortic coarctation, place cuff on the right arm not to miss recoarctation. And the devices should be programmed to record blood pressure every 50 to 20 minutes during wake hours and every 20 to 30 minutes during sleep. The more measurements you have, the more valid is your monitoring, but the higher the discomfort for the patient. So, in addition, the person applying the ABP monitor should be fully trained on the maintenance, application, and function of the device. The device needs maintenance and calibration as recommended by the manufacturer, and the cups should be regularly cleaned as well as the device. So before starting the monitoring, you should compare it with resting clinic blood pressure values, which ideally should be done with the same technique as the ABPM device to identify potential inaccuracies with ABPM. So have you chosen the right cuff? Is the placement correct? Is the device working at all? And A, to interpretation of ABPM measurements and for classification if you have the office BP in parallel. And patients should have a diary, write a diary recording antihypertensive medication administration, if they are exercising, if they have unusual activity, and sleeping and waking times. So, having done the ABPM monitoring, you should look whether the measurement values fulfill the criteria for an optimal ABPM study. The monitoring period should span 24 hours. The periods, if they are shorter, 18 to 20 hours, can be acceptable, but they should cover the nighttime. At least 70% of readings should be successful during the monitoring period, and a total of 40 to 50 readings should be available for the analysis total. You should have a minimum of 1 blood pressure reading per hour, including during sleep. However, suboptimal studies can provide clinical useful information, so it's not completely unuseful, but you should consider to repeat that in time. So, looking at the number of successful exams in different pediatric studies, it's quite interesting to see that even in very young children, below the age of 2.5, and in kindergarten children, you can have a considerable high number of successful readings and exams. So it might be still worth trying if you need to confirm hypertension or to rule out white coat or masked hypertension, provided you have the suitable equipment for the child. So then you should edit the ABPM recordings for outlying values. You have to review weight and sleep BP and heart rate measurements, and values should be discarded if they are below 60 or above 220 millimeter of mercury for systolic, blood pressure below 35 or above 120 for diastolic, if you have a bradycardia or tachycardia, and if blood pressure is pulse pressure is below 40 or above 120. And ideally, your software should already discard these limits to minimize your work with the subjective editing algorithms. So you should also discard the resting BP measurements made when fixing the ABPM device and measurements during vigorous exercise. At the end, the minimum information you should receive from your report are mean ambulatory systolic, diastolic, and mean arterial pressure during the entire 24-hour period, wake and sleep periods, the extent of dipping, which is the percent day-night difference, And you need the patient-recorded wake and sleep times from the diary to denote wake and sleep periods for analysis. For study purpose, sometimes fixed time intervals has been also used for daytime from 8 to 8 evening, and for nighttime from midnight to 6 in the morning. BP load, which is reported in some outputs, is no longer considered in the classification of ABPM phenotypes because it has been shown that it has no additive impact on cardiovascular outcome compared to systolic blood pressure level. There are a lot of other values you might derive from the outputs, but most of them are more for scientific or study purposes. And then the ABPM study should be interpreted using appropriate pediatric normative data, and they should be compared with sex and height-specific ABPM normative data, ideally obtained in large pediatric populations and not with the resting casual BP levels. And the reference values used to date are those from the German group, which were collected by Marianne Sörbel and the German working group, and we reanalyzed them by the LMS method, so also the calculation of standard deviation scores from this data set is possible. To ease this a little bit, the Hyperchild and Cost Action has developed a pediatric 24-hour ambulatory blood pressure calculator, which can be accessed with a barcode or on the website with hyperchildnet.eu, which really facilitates the classification of ABPM evaluation. So I don't have to go into detail because this has been explained in detail just a few minutes before. But again, we have some differences between the US and the European recommendations. As for casual BP, also for ABPM, the US guidelines recommend using the adult data starting at the age of 13. And overall, the limits are lower as for the casual BP, while in the European guideline, the age for referring to the adult reference data, which are a little bit higher than in the US, is also 16. And these are mostly girls. In children, where the 95th percentile is lower than the adult threshold, you should consider to look at the 95th percentile. So this will be mainly lean or short adolescent girls. So in addition to the ABPM phenotypes that has been by Janusz, we have also nocturnal dipping, which we are interested in, and the time of the day when hypertension occurs. So whether there's elevated daytime blood pressure, so normal nocturnal blood pressure, and elevated nocturnal blood pressure when daytime blood pressure is normal. And there's a correlation or an association between non-dipping pattern and end organ damage. And this is in a cohort of children with diabetes mellitus. And the non-dipping pattern preceded microalbuminuria in this group by several years. And also in children with chronic kidney disease, nocturnal non-dipping is a very common phenomenon. So over several disease entities, multicystic kidney disease, polycystic kidney disease, renal scarring, there's a considerable number of patients with either nocturnal hypertension, non-dipping, or even isolated nocturnal hypertension. And especially in renal transplant patients, there are in one study by Nico Lingens, there were 100% nocturnal hypertension and 50% isolated nocturnal hypertension, a condition you can only diagnose by ABPM. And similar to
isolated systolic or diastolic hypertension, isolated daytime and nighttime hypertension, are also associated with increased cardiovascular risk. So these are, again, data from the IDAPO study, and you can see that it's in between those with normal tension and those with 24-hour hypertension. And we also had a look in children. These are data from the 4C study. These are all children with CKD stage 3 and 4. And in this cohort, most of patients had some antihypertensive treatment. We had a prevalence of isolated daytime hypertension of 4% and 13% was isolated nocturnal hypertension. And you can see that there's a significant elevation of pulse wave velocity, CIMT, in patients with isolated day and or nighttime hypertension. And there was also a tendency in LVMA, although that was not significantly different. So the advantages of ABPM in the diagnosis of pediatric hypertension, that it provides much larger number of readings, it provides a profile of BP in the individual daily environment, it provides reducible average 24-hour day and nighttime values, it's able to identify white coat and masked hypertension, it demonstrates nocturnal hypertension and dipping pattern, and identifies isolated day and nighttime hypertension, and is a strong predictor of cardiovascular morbidity and mortality. And there are several studies showing a correlation or association between ABPM and left ventricular mass index or CIMT, which is better than using a casual BP. It is recommended to repeat measurements every 1 to 2 years after hypertension has been confirmed. And I just would like to show you this for study purposes. These are data from the ESCAPE trial, where we looked at the response to ramipril treatment in children with DKD. And on the left, you can see the change in casual BP and the change when we did the ABPM at the same point of time. You can see that the consistency is much better, and that results in the need of 60% less patients to show a significant effect of your intervention. So planning studies, it is worthwhile considering ABPM to keep patient numbers lower. So one limitation of ABPM, that it is poor tolerated. These are data from the SHIP or HOI study, where 17% of patients complained of ABPM intolerability during wake hours and 25% during sleep. And interestingly, there was a correlation between the intolerance during wake time, but not during sleep hours, independently associated with wake and overall ambulatory hypertension. So the limitations are that it's unfortunately not available in the general practice settings. So patients have to be transferred to a hypertension specialist. The measurement itself may cause discomfort, especially at night. Nocturnal blood pressure readings may disturb sleep and may have some impact on nocturnal blood pressure level and dipping, so you have a arousal reaction. And inaccurate or invalid readings during activity may influence ABPM findings and interpretation. And the availability of normative data is limited. These are mainly from the Caucasian, that's the German study, or there's another study in Asian. There will be a presentation on available other data later. So although it's not a cumbersome procedure as 100 years ago, when it was very personal, time-consuming, and also not very comfortable for the patients, we also have an alternative non-invasive continuous blood pressure monitoring device available, which makes
beat-to-beat analysis, but it's not only just photometric measurement, but also calculating the pulse transfer time with an ECG. And there's a study in Germany comparing this device with the mobilograph, and there was quite a good correlation. Sorry. Between the cuffless blood pressure measurement and the measurement with the oscillometric device, but you can also see here an example for an arousal reaction. The blood pressure increases by 18 millimeter of mercury just with the start of the oscillometric measurement. So the study said that there's only a small deviation between systolic blood pressure measured by the two methods. It's just 1 millimeter of mercury, and the authors conclude that driven by these promising results, ongoing studies should be encouraged and might promote it into broad clinical application. But the problem with this device is it has to be calibrated at the beginning of the measurement, and your examination is only so good as your calibration. But the company already extended their device, and they included a cuff which measures blood pressure actually as recommended for conventional ABPM measurements. So we have the beat-to-beat analysis in between. And maybe in the future you can consider having less often classical oscillometric measurements, but having the beat-to-beat measurements, blood pressure calculations in between, so that might be more comfortable for the patients. Okay, I think everything's said, and for time's sake, I would stop here. Thank you very much. And
thank you very much, Elke, for your very practical talk, and because of time, we have time only for one question. Okay, one.
Otherwise, we will coffee break.
So I have a very technical question. I approach this from the point of view from cardiovascular behavioral medicine. And there are two questions I have about the measurement related to quality. The first is that in cardiovascular behavioral medicine, we think it's really important to have the sampling time for blood pressure to be random. So you still randomize it at the 20 to 30 minutes or 15 to 20 within the hour, but it is not set at a regular routine, because then you get anticipatory anxiety of anticipating the readings to go up. And I have not yet seen that as a recommendation for pediatric ambulatory monitoring. So I wanted your reaction to that. And then secondarily, I completely understand the idea of you're worrying about successful readings, and if you just have too many bad readings, it's just not a good sample. I get it. But there's some information to suggest that we're introducing bias, so that individuals that have far more chaotic lifestyles, often lower socioeconomic status, in fact are the exact people that have those far less successful readings and less successful recordings. So I'm wondering if, by having the guidelines to specify that, if we also were just inadvertently introducing bias of those that are probably at greater risk of having elevated blood pressure.
Okay. So I think to have random measurements, I'm not sure whether the devices we use are able to program to have it random.
Space Labs does that.
Okay. Yes. Well, we haven't tried it yet. We have these fixed ones because we still keep the procedure that was used for the gathering of the normative values. If this is still the best way, might be discussed. Okay, and for the socioeconomic status, it's difficult to answer that.
It's about the choice to throw away data that we may be introducing bias. I give an example of SDS, but it can be part of our it's about the decision to throw away data if we don't have sufficient successful recordings and if we're introducing bias.
Okay, I think if I have a family where I know that it's quite difficult to have a 24-hour very nice profile and the child is not very cooperative, of course I would keep the data I have, at least everything is better I have over 24 hours, only 30 readings, and I have gaps overnight, than only having the casual BP readings in the office.
Professor Litvin gave me a difficult task to answer the question whether it matters to measure blood pressure phenotypes. And I have to say I have nothing to disclose except for my migration history, as Stella said. I was born not so far from here at the Polish-Czech border, so my first language was Polish. Dziękuję bardzo za zaproszenie na konferencję. And then I moved over to Canada over the last 20 years, but I keep coming back and I really enjoy coming back to Europe. Thank you. When we talk about blood pressure phenotypes, I see it as basically three phenotypes: isolated systolic hypertension, isolated diastolic blood pressure, and then systolic diastolic hypertension. And the same applies for the 24-hour blood pressure. And then combined office and 24-hour blood pressure, that creates four different phenotypes, which we call normal tension, where both blood pressures are normal. A white coat hypertension, where we have a high office blood pressure and normal 24-hour blood pressure. Then the masked phenotype, where we have normal office blood pressure, but high 24-hour blood pressure monitoring, especially the nighttime blood pressure. And then we have the sustained hypertension, where both blood pressures are elevated. So let me talk about the office blood pressure first. And I would base this on our small study, multi-center, two-continent study, where we gathered together about 2,000 children who were assessed in our centers, and they all had 24-hour, they had office blood pressure, 24-hour blood pressure measured, echocardiography in most patients, and then we classified the blood pressure or defined hypertension based on AAP guidelines from 2017. The aim of this was to compare prevalence of various phenotypes and to analyze associations between phenotypes and target organ damage. So when we look at the prevalence, I guess expected was that the most prevalent type of hypertension in children was the systolic isolated hypertension, especially in primary hypertension. The prevalence of isolated diastolic, we call it blood pressure elevation because we could not make the diagnosis of hypertension for sure because patients were evaluated in 4 different centers by different physicians. So we could only say that the blood pressure we saw, we can classify it as elevated or not. And so the elevated diastolic blood pressure isolated was, the prevalence was low, about 5 to 6% in primary hypertension, but up to 11% in secondary hypertension. And then the combined systolic diastolic was more prevalent in secondary hypertension patients. So that was somewhat interesting. And as was discussed yesterday already, it seems that the isolated diastolic high blood pressure is kind of different from systolic in a way that there is more females, younger people, maybe obese, not the leaner, and the heart rate is elevated in this group. There seems to be also some association or different association between systolic and diastolic blood pressure and the birth weight. In systolic blood pressure, there seems to be a good correlation between the blood pressure and birth weight, whereas in diastolic blood pressure there is a strange curve in patients above 13 years old. But there seems to be some correlation there. This is our study in nephrotic syndrome patients where we saw an elevated prevalence of diastolic hypertension in children with proteinuria. So we would call it some association between proteinuria and diastolic blood pressure. What really matters though is whether diastolic isolated blood pressure phenotype is associated with end organ damage, and based on this Ship-Ahoy study, there was no prediction of LVH from a higher diastolic blood pressure. There was only a significant predictor of LVMI was the systolic blood pressure percentile. In our study, I would respectfully disagree. There may be some association with in primary hypertensive patients, the isolated diastolic blood pressure elevation. It seems to give us a similar risk of left ventricular hypertrophy, the same as systolic and systolic diastolic blood pressure. In secondary hypertension, it was different, but in primary hypertension, we seem to see some sort of a signal where the isolated diastolic blood pressure does matter. We don't have too many pediatric studies, but this is a Bogalusa study where they looked at BMI, they looked at the LVMI and LVH in adults who had hypertension in childhood. And as you see from the table, there was association with BMI and systolic blood pressure, but also in the text, it's a little bit hidden, but I was able to find that BMI and the DMP showed similar patterns. So to me, it seems that there may be some signal about diastolic blood pressure and LVH in adults. This is another adult study from Korea, I think, 6 million participants, again adults who had hypertension in childhood, and it seems to me that there is similar risk for isolated diastolic hypertension or isolated systolic hypertension causing cardiovascular risk increase. This is another study in adults from China, I think, where they show similar, slightly lower odds ratio or risk for isolated diastolic hypertension, but still significant, similar to isolated systolic hypertension. And this was they estimated the subclinical target organ damage, that means albuminuria and carotid thickness. In summary of this part of the topic, I would say that the most frequent phenotype in office blood pressure is the isolated systolic hypertension. The prevalence of isolated diastolic hypertension is low, but it's significantly higher in secondary hypertension. The diastolic hypertension seems to be a distinct clinical phenotype. It may be associated with birth weight and proteinuria. It may have a similar risk for end organ damage to be confirmed in children. It appears to be associated with increased arterial stiffness and albuminuria and cardiovascular risk in young adults. Now the 24-hour blood pressure phenotypes, this is basically the numbers. If you look at the vertical numbers, the proportions of patients are fairly similar to office blood pressure. The isolated diastolic hypertension was found in 7 and 12% in primary and secondary hypertension, respectively. So very similar proportions. We found more females in the group of isolated diastolic hypertension patients. But most importantly, we found, again, a similar risk of developing LVH in isolated diastolic hypertension patients compared to isolated systolic and combined systolic diastolic. It was just published in Pediatric Nephrology last year. And there is a study from 2019, smaller number of patients, but still showing, again, slightly borderline increased risk of concentric hypertrophy with both systolic and diastolic blood pressure elevations. In a study by Dr. Hamdani and Mark and Dr. Flynn, there was no association, but this study, I believe, was meant to analyze the blood pressure load mostly, but nevertheless they didn't see association with isolated diastolic blood pressure and LVH. When we look at adults again, there seems to be association in a group less than 50 years of age. There was increased risk of isolated diastolic hypertension and the cardiovascular risk. And this is now the combined normotensive white coat mask and true hypertensive phenotypes. And this is, I think, to expect where there is increased risk of developing LPH with going from white coat to mask to true hypertension. There is more and more patients with end organ damage. Interestingly enough, even the white coat hypertensive patients, they seem to be at risk for developing end organ damage. And we are glad that we finally agree with Dr. Flynn here. It was just published, where they see the very similar findings in a more detailed analysis of target organ damage, not only left ventricular mass, but systolic dysfunction, diastolic dysfunction, and pulse-wave velocity. And they see a nice trend. The more with moving from normotensive to true hypertensive patients, there is more and more target organ damage proportion. So in summary of this part, again, the prevalence of isolated diastolic 24-hour blood pressure is about 6%, higher in secondary hypertensive patients. There are more females in this group. I dare to say there may be similar risk for LVH in isolated diastolic 24-hour blood pressure elevation. There is a high prevalence of LVH in masked and true hypertensive patients, and the ambulatory phenotypes are associated with subclinical cardiovascular injury. So to answer your question whether it matters, I think it does. I even dare to hypothesize that maybe the isolated diastolic hypertension is somewhat unrecognized or under-recognized or even under-treated in children, given all the problems with measurement of blood pressure and interpretation of diastolic blood pressure. And I would put the question back to you. Should we think about a targeted treatment based on blood pressure phenotypes? Thank you.
The measures would be 12 to 15 years old and 15 for 12 to 18 years old. And again, this is not always commercially available. And many times I'm wondering how they found these curves and they made the validation. So what curves did they use during the validation? So in my point of view, when we consider a device for validation, and I have seen this in published articles, there will be always a reassurance that there would have been commercially available cuffs. Otherwise, why to validate a device with a cuff that does not exist or cannot use? But this have never been specifically reported in the guidelines because they are made from adults. And one more comment on the cuff, and this is the rectangular versus the conical cuff. In obese, maybe we have conical arms, and maybe conical arms may be more appropriate. This has been proven in others. We try to see if this is also true for children. And we made this comparative study. We found that the two curves are mainly agreeing children, but we have a small disagreement as you can see, in 2.5% and 3.8%. But in general, the two curves gave similar measurements, and the only reason to have different measurements if the boy or the girl was very obese and would have a very conical arm, or if there was an increased lean mass, or we would have a lot of mass if there was a lot of mass in behind. So how accurate are the validated devices? And what I want to show that the criterion 1 and criterion 2 are used for validation of devices. For criterion 1, high accuracy device means a mean difference NSD of mean difference of 0 and NSD 3 to 6. For moderate accuracy, mean difference of 4 and NSD of up to 5. And then move forward of this meta-analysis we did, and we found that for at least for office blood pressure, there is only 20 validated devices and most of them are not actually available in the market. But I will move to this slide. This is unpublished data and are going to be soon submitted for publication. And this is the office blood pressure devices that have been validated. And I want to show you the mean of criterion, the mean difference. And you can see that most of the devices, they don't have a mean difference of 0, which means in a high accuracy device, but they have more than 5, and NSD ranging 4 to 7, so actually they're mid or low accuracy devices. So what about the out-of-office blood pressure devices? Then we did a meta-analysis, it's again a published data, 10 devices for ABPM, 6 devices for home blood pressure. I can answer to you that only one home BP monitors are commercially available. Most of the ABPMs are available. This is the good news. But let's see how reliable is the validation. And here we can see on the left we can see the home blood pressure, on the right the ABPM. And you can see for home that most of the devices, they have huge, this is the 4 devices, they have huge mean difference. And actually for systolic, and this is for systolic blood pressure, and actually this is the yellow, and actually they have a very big RSD. The situation is much better for ABPM, only the Space Lab 2017 that we usually use is not so accurate. And then again, SD is not so big. So home blood pressure devices are of low accuracy. This is what I want to point out, and this is about only the current validated devices. And we will go ABPM versus home versus office. We can see that ABPM devices that have been validated are the most accurate. So ABPM is not only a good method, but also we have the best devices, while the worst devices are home BP devices that are validated for the moment. And I'm moving forward. This is a position statement from expert group. And what I want to show is that, okay, they say about office blood pressure, but what they discuss here, the normal blood pressure values may be according to methodology. And this is an important question if we use oscillometric devices. They are for low accuracy, but can you use the oscillatory reference values? And I want to present the data from this very beautiful study from Professor Sulakova that compared the performance of GIGS reference values from their task force using to see the performance of oscillometric device. And what they found that it's different both in systolic and diastolic blood pressure percentiles when they use the different percentiles. Of course, there was a good agreement for systolic blood pressure, so you may use it for systolic blood pressure, but you can see here the agreement for diastolic blood pressure is less than poor. And but when they tried to see if they could predict ambulatory blood pressure, actually both reference values they couldn't predict very well ambulatory blood pressure. You can see that the area under the curve is below 70. What about predictive value on target organ damage? And actually, this is a study from LA that showed that actually oscillometry measurements also for central blood pressure, they didn't perform very well compared to auscultation to predict target organ damage. And you can see here the blue line that is auscultation, that has an area under the curve that is much, it's 0.8 in 80 and much lower when you go for auscultation. And also you can see that there is no very good, when you go for prehypertension, it's almost the same, also the same. This is not the scaling way you go for normal, high normal and hypertension when you use auscultation. So it would be my conclusion here that if hypertension is detected by the oscillometric method, it needs to confirm using auscultation, and this is where all guidelines are giving hands. So I think this is a very important point that it should be my main conclusion. We're looking to the future, but all this I'm talking about is actually present or even past, and it's very important. But if we don't go well with validation with the current devices, what about the other devices? And this is an Australian study. This is my last slide, where you can see that with the new devices, almost in some with the recent devices, and this is for others, none of the devices was validated. And actually, this is what people were buying from the internet to measure his or her blood pressure. So in conclusion, auscultation remains the gold standard for diagnosis of hypertension. There's a low number of oscillometric blood pressure measurement devices validated for children. Oscillometric devices should pass validation totally with reliable accuracy, and this is needed both for research and clinical settings. Thank you. Please remember that IFA is a very good organization, and for all those that work on hypertension, you should register. And for those that in Europe, please remember to come in Athens in October. We will have a lot of nephrology topics, also hypertension topics. Thank you.
Thank you, Stella, for excellent talk, which is open for discussion. First question from Joseph.
So that was fantastic, Stella. The question I would have for you is, in adults, because of fixed cut points for diagnosis of hypertension, the oscillometric devices are acceptable and even recommended. In children, since we have varying levels of blood pressure according to
age and height, and added a 90th percentile for high blood pressure. Then they came, that was in 2004, with the fourth report, defined prehypertension and recommended assessment for evidence of target organ injury. And that was sort of the major operation. This is the first time that was recommended to look for evidence of cardiac hypertrophy and pulse wave velocity. So, and then we get to 2017, and this is when a substantial change was made with the observation that overweight and obesity were significantly associated with high blood pressure. So the data, the distribution tables for blood pressure at the 90th percentile and the 95th percentile dropped, right? They moved after removing participants who were overweight and obesity. So when that happened, the blood pressure and the definition of high blood pressure for the 95th and the 90th percentile dropped, right? And the timing of that was kind of, caught people around it. The different guidelines were always following this sort of table, of the distribution of normal blood pressure. So the change there was the removal of obese children in the distribution curve, and also beginning to use static numbers for the definition of hypertension for adolescents. Right? So these changes are basically based on sort of, progress in understanding of high blood pressure and abnormal pressure in adolescents and children, but also it was going on in different groups around the world and trying to sort of keep up with the issue. So that sort of, we have to find out ways of smoothing this out about the changes as we learn more information. The one thing that we could probably agree on is how to measure blood pressure. This photo is just for a publication, and we have to be very careful about making it, the artist to get everything just right. With this child sitting in a chair, feet flat on the floor, back supported, arm at the heart level, the right side cup, all of these to make the blood, to measure the blood pressure accurately. Except, at the time, look at the monitor, right? All of our blood pressure data, our reference data is by auscultation. So another issue that arrives is what devices we use to measure blood pressure, and should we always do auscultation at least for confirmation. So there are some differences in definition of hypertension currently, and as you can see, it's mainly for the static numbers, and the static numbers, I think, are developed just to help clinicians kind of not miss high blood pressure. So the static numbers, as you can see, are a little different between the American Academy of Pediatrics definition of hypertension, starting at 813 versus the European Society of Hypertension puts at static numbers at 140 at the age of 16 and beyond. And then there's another one for Canada. And so this is another thing that we can probably need more work on getting consistency. So this, the US guidelines for hypertension treatment in hypertension treatment in children without diabetes or chronic kidney disease is at the 95th percentile or 130 over 85. But in the guidelines, there's this statement by you-know-who, Flynn in pediatrics, is that in addition, there is some evidence that targeting blood pressure less than the 90th percentile results in reduction in left ventricular mass index and prevalence of left ventricular hypertrophy. Therefore,
Doug Blowey wrote that sentence.
Therefore, an optimal blood pressure level to be achieved with treatment in childhood hypertension is less than 95th percentile or less than 130 over 80, whichever is lower. So we see we have some sort of variation in how we're going to treat at target. So the other thing that I think I've shown you this slide before is the trajectory analysis on sort of longitudinal cohorts. And in this particular report, the cohort was followed from 7 to 38. At 38 years, the investigators classified the at that adulthood, at that age of adulthood, as those with hypertension, pre-hypertension in green, high normal in blue, and then normal in red. And I think the things that is notable is that in childhood, the trajectory curves begin to become clear in around 11 to 12 years of age. You can see the pathways just separating. And the other thing is that they deviate at around 120, right? And it's like if you get an adolescent to, become an adult with a blood pressure of 120 systolic, that would be kind of a good thing to do. So it's this, when adolescents begin to exceed 120, which is around what we think is the 90th percentile, it is something to consider to intervene. Right? So now the other thing that has advanced are sort of efforts to diagnose and manage hypertension in children is the issue of outcomes. And now we're sort of beginning to see some evidence of outcomes. And this is a slide that shows what are the outcomes of children with pre-hypertension by the time they are adults. And you can see with pre-hypertension, there is significant risk for adult hypertension, and then some target organ injuries, including high pulse wave velocity, higher intimate thickness, and higher left ventricular hypertrophy. You can see the hazard risk on the right side. And then for childhood hypertension, children who have blood pressure above 130 or 85, that's even higher risk as for adulthood. So this is beginning to show us some outcome data, right? We've always been using the percentile because we haven't had outcome data. Here is, the beginning of changes. And these are, this is a slide of the Shipahoi study, which shows that even below what we call hypertension or elevated blood pressure, you can see some signs of target organ injury. The Shipahoi study looked at blood pressure below the 90th percentile to see if there was some evidence of injury below that. So this slide shows that the mid-level the children, adolescents designated with mid-level blood pressure also have some signs of target organ injury. And this is the same thing with the pulse wave velocity. So right now we're beginning to see some shift in what is the significance of blood pressure, even below what levels we've been following before. And this is a slide that from Elaine Urbina about the IC3 cohort, which was really longitudinal cohorts that we considered the Bogalusa study and the Muscatine study. So there are long-term data on these cohorts, and they went to find out what were the outcomes of these people who are now in mid to later adulthood. So this is more hard outcome data, and this slide just shows the the difference in hazard ratio according to the different outcomes based on body mass index, blood pressure, systolic blood pressure, and triglycerides and total cholesterol. So you can see the red is the highest risk ratio, and the orange is the elevated, and the yellow is high normal. So the and this is a more difficult slide to read, but if you look at the top for blood pressure, which is you can see the blood pressure. The top is the white box here gives you the numbers for the high risk, or it's not, the red is the highest risk, this is the borderline, and you can see at the middle point, the 116, this is the level of moderate risk, and if you go over to the right to find the level in the girls, it's the high risk blood pressure is 111. So this needs to be followed more, but we know that the difference changes. So the other thing to think about, and that's shown in this previous slide, is the other risk factors for target organ damage. So there is that more risk factor in these patients have not just high blood pressure, but they also have obesity, dyslipidemia, diabetes, or abnormal glucose, and metabolic syndrome. We have to wonder if we need to fit that into our assessment and decision about what levels we need to use. Now, these recommendations are all based on reference data that's been obtained by auscultation, and the question then is, going forward, how are we going to do? Are we going to abandon auscultation with all of the devices that are now becoming available? Or are we going to, develop different tables based on devices, right? So there is increasing evidence that the threshold for target organ injury in adolescents with primary hypertension is less than 90th percentile. Evidence from the IC3 consortium demonstrates that systolic blood pressure less than 120 in adolescents has increased risk. So clinical trials are needed to determine if hypertension associated with target organ injury in adolescents can be reversed, and outcome-based clinical trials on adolescents with primary hypertension are needed to determine if lowering systolic blood pressure to lower levels improves the outcome. And much more research is needed on multiple risk factors and how much that adds. And my hope is that you continue to measure blood pressure by auscultation. It's an important skill to maintain. Thank you.
Thank you, Bonita, for your excellent overview talk on standards of blood pressure in pediatrics, and the talk is open for discussion. May I start. Do you think in the era of globalization, will we ever reach a global definition, worldwide definition for blood pressure, high blood pressure, elevated blood pressure, target blood pressure in the future?
I think that's that's a hope, but challenging to get to, and it's challenging because we have different access to health care in some differences in countries around the world or continents. We have really, I mean, if you look at the World Health Things, I mean, abnormal blood pressure is continues to be the leading cause of non-communicable deaths and disabilities, right? So, it's not, we should, be doing this and helping people to understand it, but how much it is a priority, how can we make it a priority that children should be followed? I think we have a long way to go. So it's something that we should strive for, but it's hard. It's hard. Right. So, but it only took 50 years to get here from the first set of reference data. So.
One more question for Manish.
Benita, just extending that previous sort of question. So, a lot of parts of the world, one of the big sort of blocks to measuring blood pressure is the patient coming back for another BP measurement. And do you think we should consider a single time point measurement, at least just to tell us whether this is hypertension as opposed to no tension and not have any more precision? Because a lot of healthcare models can't get people back into, and therefore people don't measure.
Right. And actually, sort of a correlate to that is the more we know, the more we make it more complicated, right? To make a diagnosis of hypertension. So I guess we could try, doing. It is, you can't make a diagnosis on one measurement, right? It requires more measurement. Unless, it becomes standard measurement for pediatricians, right? And it actually has taken a long, it wasn't until the fourth report that actually pediatricians began really measuring blood pressure as part of the standard care. So, that's basically, the place, the pediatricians are the ones that we need to get them, make it easier and empower them to measure blood pressure. And then, we got some other ones, the overweight and obese children. There are kids that are in, stress and lots of problems. I mean, it's a lot of things we can do. But to answer your question, it's still we need to have multiple. So good luck with that.
Okay, then thank you very much for the talk and for the discussion.
So we're now moving to the next speaker, which is Professor Horvensiek.
and he's from UK, from the British Hypertension Society. He will speak on neuroeconomics, and we are eager to hear from him.
Thank you very much indeed, and it's a real pleasure to be here. Thank the organisers for inviting me. As you see, I have a Polish name. My father was born in Warsaw, so it's a real pleasure to come back to visit. So I must emphasise this is a personal view, really. The British and Irish Hypertension Society, we're developing a position on this, but this is a purely personal view on some new ways of looking at measuring blood pressure. These are my disclosures, but I don't have any relationships with any companies that are active in this area at the moment. So I'd like to cover where we are now, really, and then the opportunities for the new technology, and most importantly, how we might assess this. So our current technology dates back, as you know, a long way to the Riva-Roci cuff, and then the use of the stethoscope to obtain blood pressure, and then finally oscillometric methods, which, as Professor Faulkner has described, are referred back to the stethoscope as the current gold standard. There are limitations with this technology. So this is a study, one of many, where simultaneous measurements of oscillometric blood pressure have been made with intra-arterial. As you see, there's a very wide scatter here, broad limits of agreement between the two. And perhaps more importantly, there's a lot of variability in blood pressure. Now, some of that is physiological and very important in its own right, but also the variability comes from measurement error. And I won't go into the details here, but this was actually some work done by an astrophysics PhD student, and astrophysicists understand uncertainty science very well, and you can demonstrate that you may think you're measuring a blood pressure, but actually what you measure is very different from that, and that will result in a lot of misclassification. Even if you use ambulatory blood pressure, you will misclassify a surprisingly large proportion of people. And that's because a large proportion of people are in the middle ground. And that's not just for diagnosis, but it's also for treatment. So you'll misclassify people that you think are controlled and are not controlled. So the cuff-based blood pressure, it's got its problems. It's a little bit of a cumbersome technique. It influences what it measures, well no, and there's this measurement uncertainty, which I would suggest is perhaps not being studied as much as it might be. But still, as Professor Faulkner's said, it's one of, if not the most important tool we have for public health, because it identifies very high blood pressure, it's a validated measure of risk for everyone, and it's a validated target. So it's incredibly important. So what are the new technology? Well, the technology that I'd like to talk about is this optically derived waveform, called photoplethysmogram, or PPG. And this is the waveform that is incorporated into almost all devices. So all smartwatches incorporate this waveform. They may not display it for you, but they've got it in there because the manufacturers want to be able to use it at some stage. You can get it by putting your finger over your phone, the camera on your phone, and you can record the waveform. And then in principle, you can get it from light reflected from a screen, so it can be completely contactless. So wouldn't it be wonderful if we could use this technology to measure blood pressure? So it's very difficult to get a young person to in contact with a cuff, but you can't part a young person from their devices. And this, as you sit here, your blood pressure could be measured continuously if this worked. It's a big if. And then, when you go through passport control, you can have your blood pressure stamped on your passport. So, the potential, if it worked, would be huge. would be a game changer. Now this waveform, the PPG waveform, has been around for a long time. So you'll be familiar with it as paediatricians. You know, every time you go into the emergency room, you have somebody hooked up to a pulse oximeter. You see this waveform on the screen of the oximeter, and it's measuring the density of red blood cells in the capillaries. And if you want to measure oxygen saturation, you measure it at two different wavelengths so that you can see the saturation of the red blood cells. But the waveform itself, you only need to measure at one wavelength. And the size of the waveform, the amplitude of the waveform, is totally dependent upon the perfusion of the tissue that you've got the light over. But the shape of the waveform is determined by ventricular vascular coupling, and so is related in quite a complex way to hemodynamics. When we were started getting interested in this is 25 years ago, it was with Sandrine Milzo, who was my first PhD student at the time. She was an engineer, and we looked at features of the shape of the pulse, and we were interested in looking to see whether we could measure arterial stiffness, and we showed reasonable association with carotid femoral pulse wave velocity. So a reasonable association. So you could estimate it. We looked at this with machine learning, see if we could improve on our very simple derived estimate, and we couldn't really. And then I'll show you this study just to illustrate how easy the technology is to apply. I mean, this was done with a finger probe, but you could just do this with a phone camera, you would get exactly the same results. And one of the important things about this waveform is that it's very robust because it's an optically derived waveform. You will get the same waveform pretty much whatever device you use to record it. And also you get the same shape of waveform pretty much wherever you record it in the body within broad limits. And so this was a study where we had a medical student, Chris Broy, whose father was a teacher at the local college, and we were looking at the association of arterial stiffness with birth weight. And just to show you the ease with this, which technology can be deployed, this was a study that was done in a day, because he went round his father's school and measured all the children in the school and asked them to get their mothers to tell them what their birth weight was. And we showed quite a marked association, much more marked than with blood pressure, with birth weight. Now that's by the way, but it just illustrates the ease with which the technology can be used. So what about estimating blood pressure from it? Well, we know much more about the physics of this now. There's been some elegant computational modelling done on this. And we know exactly what determines this waveform. It's a very complicated interaction between ventricular ejection and the characteristics of the arterial tree. And that's primarily what determines it. Of course, all these things are related to blood pressure. So, in principle, we can estimate blood pressure from it, but only if the physiology is stable, by which I mean there's a fairly constant relationship between ventricular ejection and the properties of the arterial tree, and that we control for all the confounders. So how do you do this? Well, you need a young professional with a laptop. There are various acronyms for this, which I won't bother you with. You need to record the waveform in a large number of people and have a reference, and then you can do it with machine learning. And that's going to give you the optimal extraction of blood pressure. And the details of the machine learning, there are lots of different techniques that you can use. You can take various fiducial points on the curve, you can then differentiate it, get derivatives, obtain further fiducial points which relate to the curvature of it, or you can just look at the whole shape with deep learning. And it doesn't really seem to matter. The point is about with all of this machine learning stuff is what really determines how well it works is the underlying principles and the reference data that you use. Now, this is what possibly is the market leader in this PPG technology, and it's certainly the device that I work as an adult hypertension physician in an urban area, and a few of our patients come, they commute in from the affluent suburbs, and this is the device that most of these people use, this Actia device. It's a bracelet which has got a PPG in it, then it's connected up to some sophisticated software. And the way that this works is, to get over this problem of the link between, the indirect link between blood pressure and the PPG signal, is that you calibrate it against the cuff. And then this device has been tested against, what's a recognised protocol for these types of devices, and it does pass the protocol, and there is reasonable agreement. But of course, you do have to calibrate against the cuff, which is a bit of a disadvantage. And the other thing that I worry about is whether our protocols for validating these are adequate, because as I said, this relationship between blood pressure and the shape of the PPG is very indirect, and it's dependent upon stable physiology, and that will vary according to physical, mental activity, night, day, and notably these devices don't seem to work as well during the night because all the machine learning has been done on them mostly during the day, and then when you treat people, you'll get different values. If they've got some cardiovascular disease, you'll get different values. So I think this has to be taken with a bit of reservation. But we may be getting a little bit fixated upon the accuracy of measuring cuff blood pressure, the accuracy with which these devices measure cuff blood pressure. And I would put it to you that maybe cuff blood pressure isn't the thing that we want to think about. What we really want to know is whether people have got high blood pressure that needs treating, or whether it's low and we can just give them standard population advice and reassure them. Most of the people I see come into the high category because they've already been through primary care. But of course, the majority of people have got middling blood pressure, and that gives us all the problems that Professor Faulkner has just been discussing. So we mostly just worry about these people. The other thing is that most people fit into this category. As we've just heard, the thresholds, we're continually changing a little bit. And then, as I've pointed out, even if we know what the thresholds are, we can't measure the blood pressure accurately enough. So this middle area here is a huge problem. And what we're moving towards, as again we've heard from Professor Faulkner, is assessing target organ damage. And in adults, cardiovascular risk, probably not appropriate in children, but certainly target organ damage. And the PPG has the potential to do this. And so maybe we should look at this as well as its ability to estimate blood pressure. So when we were looking at this technology, we persuaded UK Biobank to include it in UK Biobank. And so this was again a finger probe based measurement, but you could measure this with a camera on your phone, or you could measure it with a smartwatch, whatever. It wouldn't make any difference at all. This was just recorded for a few heartbeats in UK Biobank. It only took a few seconds to do it. They also recorded at the same time a couple of conventional oscillometric measurements. So this was over 100,000 participants that we now have 10-year follow-up on, and they've had, as you see, nearly 10,000 events. And we can look to see how well we can predict events, which certainly in adults would be, arguably more important than the measurement of the blood pressure. But before we do that, let's just have a look at how well the PPG performed in terms of looking at office or blood pressure, the two measurements that were made. As you see, there's a correlation, but massive limits of agreement. So if you just looked at this, you'd say, well, is this really, any use at all? But we also have to bear in mind that, a couple of measurements of cuff blood pressure aren't that good in themselves. So this is different data. This is looking at, again, 2 measurements of cuff blood pressure against mean daytime systolic blood pressure. This is mean of multiple ambulatory blood pressures, so it's as good as you can get. And as you can see, the scatter is pretty much just about the same as I've shown, and I've shown you previously, the poor agreement with intra-arterial. So that the data, this data is not in itself is not sufficient to write off the simple PPG estimate. And this is uncalibrated PPG, so there's no cuff being involved in the calibration. So this is just something that you could get instantaneously from the PPG you get on your phone. But if we looked at events, now this is quartiles of PPG. These different curves here are quartiles of the PPG estimated risk with adjustment for classical framing and risk factors, age, sex, lipids, etc. And there are highly significant differences, so it does add to risk prediction. This is the additive value of the PPG to conventional risk factors, looking at the C statistic, and you get a modest increase in the C statistic, which in predictive terms is actually quite big. Much bigger in younger people than in older people. Now, I appreciate that it's very disappointing not to have any data in younger people, but the world is getting younger in more ways than one, and I would put it to you that we should, 50 is really very young. I mean, Manish is just a kid, really. I'm middle aged. So we don't have data in younger people with events, but I've already shown you we can predict arterial stiffness. I haven't shown how well in comparison with other things, but it's likely that we can also predict left ventricular hypertrophy. That's work in progress at the moment. So where I think we are on this is the accuracy for true blood pressure measurement is yet to be determined. There is potential to improve upon cuff-based screening. The data I've shown you in Biobank would suggest that. And just to add to that, the prediction from the PPG was actually better than if you had to choose between the 2 ordinary measurements of cuff blood pressure in Biobank and the PPG. The PPG outperformed the cuff blood pressure. So on the face of it, just on that, there's lots of reservations with that data, but I think we can say there's potential, certainly not proven. And then there's certainly also the potential to look at target organ damage. But we could simplify this even further and say that, look, what's really important is at the end of the day, whether somebody starts on treatment or they don't. And we have, we're developing, as we've heard, robust algorithms with standard methods to do that. And we can ask the question, can the PPG predict that? That's a very pragmatic, simple thing to do, which I would suggest is the way forward in assessing this technology, rather than getting overly fixated upon whether it measures a cuff blood pressure. So, in conclusion, it's got the potential for estimating blood pressure. I would suggest that it's probably never going to be as good as a cuff-based measurement, but we'll see. Certainly got potential for cardiovascular risk, target organ damage. And then the thing that we haven't tested is whether it's good at doing what really matters, is telling us whether somebody really needs treatment or whether they don't. And that would be a relatively simple thing to do. So the evaluation of this really requires some prospective studies. It requires standardization, and unfortunately all the manufacturers are not very keen on giving a standardized output, so they're all producing devices which produce rather different measurements. So we really need some collaboration between industry, academia and healthcare to take this forward if we're not going to have to wait a long time to get some really what are relatively simple answers. So I'd just like to finish by acknowledging some of the people that did the work I've shown, maybe particularly Dr. Ye Li, who's currently working on this from the biobank data. So thank you very much.
Thank you very much. This was an excellent perspective of what we can do in the future. So,
thank you very much for your presentation. Really nice, really exciting. And my question is your opinion about age categories, because the basal physiology, which is adults in children, in age children categories, and also in very old people. So which age category is appropriate for this measurement?
Well, yeah, thank you for your question. In terms of how robust a signal this is to recall, you can record it very robustly in young people. So as I say, in neonates, you have it on the pulse oximeter, so you can see it yourself, how easy it is to record. There's a big history of using this waveform in animal work. You can, it's a very easy waveform to, and of course, in terms of how it relates to physiology, this will change over the life course, and so that's the problem with these types of studies which work on reference values with machine learning, etc. You have to be very, very careful of the reference data, so it has to be derived in the target population, and then you have to be very careful about the way you evaluate it, because if you just evaluate it by equivalence to a blood pressure measurement, then that's potentially quite misleading, because you're not going to pick up all the potential confounders, particularly confounders like treatment. So that your question is key. You have to do the work in the target population at all. But it's very easy to do. That's the great beauty of it, because your august faculty here are experts in the assessment, and this is a very easy measurement to make. So it's just a question of linking the two up and assessing it.
I'm over here. Next question. Related question about how this works in black ethnicity of more pigmented skin, and whether the validation work in African populations.
Yeah, I think it. So as you know, there's been concern about pulse oximetry with black skin, but I don't think this applies to this, because with pulse oximetry, you're doing something more complicated, which is differential red blood cell absorption at two different wavelengths. This is just absorption at a single wavelength. So I'm not aware of any data to answer your question properly, but in terms of theory, you wouldn't really think it would affect it. What I suppose my other comment is that it does depend a little bit on perfusion. There are a lot of devices now which are, you've probably seen them advertised. You can buy rings which have this PPG in them, and people that have cold fingers, and then going into Raynaud syndrome and so forth, it's not going to work there. But you can just put it in a different place, you see, because the waveform doesn't really depend where on the body you put it. There's a bit of dependence, but all these things get ironed out by the machine learning.
Thank you very much.
So it's my big pleasure to introduce the next speaker, who will be my co-chair and friend, Stella Stavoli. Professor Stavoli is a professor of pediatric nephrology at the Aristotle University of Thessaloniki in Greece, and he will talk about automated or auscultatory blood pressure measurement.
Thank you very much. And I'm really glad to be here today and listen to all these marvelous talks. And this is actually an exciting meeting for me. I have no conflict of interest, but actually I will share a lot of personal views, and I'm happy that my personal views are in agreement with Professor Falkner and also with the previous speaker. So moving forward, I have to say that auscultation started a long time ago when humans used senses and skills to measure blood pressure rather than technology. So the first effort started on 1733, and I will not go through everything, but I want to point out that in 1976, and this is here, is when the first automated oscillometric blood pressure monitor arrived and patented, and then everything else started. And then let's move forward. For the oscillometry, what we need is the cuff, the monitor, then there is the pulse wave. Then as the cuff is inflating, there is this pressure transmitted to the vessel, and then the blood flow stops, and when it deflates, we have this oscillometric signal that is needed, that is used to measure blood pressure. And moving on to much more details, and this is for British Hypertension Society, one statement on technical notes. We can see that during the implantation, we have these oscillations. Then when the cuff occludes the artery, then there is no more blood flow, and then the oscillations stop. And then during deflation, at some point, there is again the oscillations, and then this is when this envelope, this oscillometric envelope, is designed and is used to measure oscillometric blood pressure. But on the second figure, I want to point out that it's not always the same. It may depend on increasing blood pressure, and will be different. This envelope will be different when you have a normal blood pressure, an optimal blood pressure, or a high blood pressure. And of course, there is more technical issues because several parameters, but also the method that the device, the algorithm that's inbuilt in the device, is different in different devices. There may be errors, and this is one method of measurement, of calculation and of an algorithm. This is the fixed ratio method, where the amplitude, the maximum amplitude compared to systolic and diastolic amplitude is used. And it may results to a lot of bias and errors, and you can see on the second figure that when you have a normal blood pressure, it may be okay, but when you have stiff arteries or very compliant arteries, then you may have erroneous measurement. In a stiff artery, we have a longer pulse pressure, or in compliant arteries, we will have a lower pulse pressure. And let's come to our population, to children, and let's see what comparative studies exist on auscultation versus oscillometry. And I want to remind that, of course, the gold standard is mercury sphygmomanometer. And now we have the hybrid ones because we know it's not environmentally friendly. And of course, we have the anaerobic sphygmomanometer. And just want to remind that this was 6 to 12 months calibration. So it's not like mercury we need to care about our instrument. And of course, it's a variety of oscillometric devices. That's point one, no conflict of interest on this. And I will present you two different meta-analyses on the comparison of oscillometric and auscultation measurements. This is the first meta-analysis, was published in 2017, and actually what it was shown by the authors is that there is a slightly higher blood pressure levels that are measured when you use oscillometry compared to auscultation, but still there was a good agreement between the measurements. So the authors have concluded that you can use oscillometry to measure blood pressure in children, but they also try to find out what parameters are influence these differences, and what is the most important difference. Among these, I want to highlight that it is the validation that plays a very important role. So if we use an accurate device, we may have a smaller difference than if we don't use an accurate device. And you can see that devices that are past the validation procedure, they have a difference for systolic blood pressure of 1.76 compared to 4.48 when a non-validated device was used. Similar findings on this second meta-analysis that was published on 2022. And we can see here in this figure that the authors have different rows. And I want to point out to you that here is by devices validated by AAMI, by British Hypertension Society, by European Hypertension Society protocols, and I will speak about the protocols in the next slides. And we can see that the agreement or the difference when these devices are validated is small compared to devices that were not validated. You can see that the diamond is and the difference is bigger. Similar findings for the Thomas. For the solid blood pressure, a big difference when the devices are not validated. And let's move on to validation studies and what are the criteria and issues on validation studies in children and adolescents. And because of this hyperchild post-action, this was a very important networking action we had in Europe under the lead of Empire Lurben and Elke Fuhl. And when I was first asked to work on working group of devices, I was very scared and not very excited, but I learned a lot through this search of the hyperchild net. And this is the table, this is part of the table of one of our publications that shows the criteria used from different organizations that are target on pediatric populations. And when I say pediatric populations, it's strange because what is considered pediatric population in all these organizations in children is children below 12. And I will comment in the next slides that adolescents over the age of 12 are considered general population and are in the same group as 80 or 90 years subjects. So this is impressive. But this is adult guidelines, that's why they fit the adolescents in adults, in older adults. So this is the three organizations that have criteria for children younger than 12 years, and we can see the numbers that are needed for validation. For the British Hypertension Society criteria, we need 30 subjects. For the AAMI for 2000 ISO 2013, we need 37 subjects, 85 subjects if the device is only for children. Then for the last criteria on 2018, if the device is validated is for general population, then out of 85 participants that are needed for the validation of the device on the general population, we can use 35 persons, 35 subjects for children up to 12 years. And all these are surprising for me. And if we need to go only for validation of a device, we go to 85 subjects. This is because when they read the guidelines, they say that they decided that we need 85 subjects in order to have a good accuracy of device. So when you mix adult and pediatric populations, many issues may arise. And one other important comment I want to make is about the reference diastole blood pressure. Of course, expectation is a reference for this criteria. Is that K5 is for British Hypertension Society, K4 is for the other societies, for that organization, which is not according to the published guidelines in children and adolescents of the American guidelines in 2017 and the European in 2016. And let's go to sample size. There is a disagreement on the ideal population sample, so depending on the criteria of the organization you have used, you may have different power of the validation. And as I commented before, adolescents older than 12 years are considered to be in the general population sample within an 85 population sample. And this is what made me consider and question myself, and actually question everybody, does blood pressure measurement in adolescent lie with similar properties to adults? And what we know is that the algorithms are variable devices and they are considered proprietary of the manufacturer, and therefore they are confidential. So we don't know if they fit with the same accuracy for adults and children. And also the algorithms are developed for adults who usually have a higher blood pressure level. And of course, automated initial calculations to high pressure may cause discomfort and pain in child, and that may reduce its cooperation. Oscillation also, we know that many times is lower in the youngest, And of course, we know that the pulse wave contour is different than the older individuals with the stiffer arteries. We know that children may have less stiffer arteries and but also more compliant arteries. So a low accuracy device for adolescents, and I will show you in the next slides that this is happening with an image algorithm may result in high accuracy when we speak for older adults with a higher oscillation and with higher blood pressure. But if we have adolescents in the same study, then this would result in a low accuracy device for adolescents. And this may be important because this may classify adolescents and this may be results in undiagnosed hypertension for them. Let's move forward about the cuff size, and what this organization asks is that the cuff size would be available for different arm sizes. What they ask is that the length covers 75 to 80, 100% of the arm circumference. This is again different than our guidelines, where we say 80 to 100. Many manufacturers of the devices that have been validated, they only include other cuffs that are suitable for arms all greater than 22 centimeters. So let's see. For years 12 to 15 years, the 25th percentile for mid-arm circumference is below 20. So we may validate a device and we may not have an appropriate cuff available, similar for boys. And then the guidelines also recommend that
guidelines about blood pressure in children. And there have not been much measurements of blood pressure in children, and it really wasn't, they always thought that it was, if a child did have high blood pressure, it was probably due to some secondary disorder. And they used the adult definition, right, at that time, before 1970. So this task force came up with a definition of hypertension in children. There was no long-term data as to what blood pressure, what the adults had for outcomes. So they used the first time the 95th percentile. And there were some blood pressure data that were used to develop this 95th percentile, but it was not very much or very large. And also the measurements of blood pressure were not really very clear in children at that time. So anyway, they presented the curves of the 95th percentile and had a definition of hypertension that was for childhood, not adulthood. And but it looked like the curves were kind of high, particularly for late adolescents. So a second task force was appointed to update the information, and they expanded the database with drawing up at the reference data on 60,000 children. And that had much more reasonable blood pressure distribution. And the next was an update, which was in 1996. And the update presented data on tables, right, not curves, right, and they presented it. So I'm thinking here, the issue of blood pressure standards, well, we keep changing that. We keep changing our standards, right? And it's because of what we've learned about blood pressure in children and about measuring blood pressure. And I'm kind of take you through the history of what we've been doing in the US with our guidelines. And the story starts in the 70s, 1970s, which the National Heart, Lung and Institute, not Heart, Lung and Lung Institute, appointed a task force standards.
First of all, I would like to underline that in recent years, some guidelines have changed the nomenclature of different blood pressure statuses. However, regardless how we call it, if it's high normal blood pressure or prehypertension, we are talking about blood pressure values between normal or optimal, depending on the definition, and hypertension. I would like to start with what is prehypertension, how often it occurs, highlight the complications of prehypertension, and finally I would like to talk about evolution from prehypertension to hypertension. We all know that blood pressure can be classified based on office blood pressure and ABPM or home measurements, but it should be noticed that there are some differences resulting from the geographical location and guidelines we use to classify blood pressure. And starting our journey from America, we all know that based on fourth report published in 2004, prehypertension was defined as blood pressure values between 90 and 95 percentile, or blood pressure values exceeding 120/80. After 13 years, in 2017, next American guidelines has been published, and the term prehypertension has been replaced by elevated blood pressure. Definition is the same exactly. However, patients are also divided into two age categories, under 13 years of age and 13 years and older. In this older group, we should treat these patients as adults, and elevated blood pressure is defined as systolic blood pressure between 120 and 129, and diastolic blood pressure below 80. Now going to Europe, based on the latest 2016 European Society of Hypertension guidelines, we have high normal blood pressure category, not prehypertension. And according to these guidelines, patients are divided into two age categories, 0-15 years and 16 years and older. As previously, this younger group should be assessed by percentiles, and patients 16 years and older this time should be treated as adults, and high normal blood pressure is defined as systolic between 130-139 and diastolic 85-89. The same values were adopted for our Polish guidelines published in 2019. This blood pressure status was called high normal / prehypertension. We all know that when possible, elevated office blood pressure in children should be confirmed by ABPM or at least home measurements. And based on American Heart Association guidelines, ABPM guidelines from 2014, and based on the latest 2016 European Society of Hypertension guidelines, so taking both into account ABPM and office blood pressure measurements, we have category of prehypertension, which is defined as office blood pressure equal to or exceeding 90 percentile, mean ambulatory systolic blood pressure or diastolic blood pressure below 95 percentile, and blood pressure load, systolic or diastolic, equal to or above 25 percentile. In our Polish guidelines in 2019, we added the information that not only in office blood pressure, but also in ABPM, we should use adult cutoff values, so 130/80 for abnormal ABPM, 24-hour blood pressure in this population, older population. In 2022, next American Heart Association guidelines has been published, and using, as we know, using blood pressure load was abandoned, and ambulatory prehypertension category was removed. Also, there is no division of hypertension on ambulatory and severe ambulatory hypertension. Referring to this famous cartoon, Finding Nemo, I heard that after publication of these guidelines, the producer started to think about the second part of the movie. Going to the prevalence of prehypertension in children and adolescents, we all know this fantastic review and meta-analysis by Song, and the pooled prevalence in this analysis, prevalence of prehypertension was around 10%. In another study, Canadian study on a group of adolescents, 14 to 19 years old, prehypertension, defined based on office measurements, was diagnosed in 12% of rural and 21% of urban adolescents. Numbers are higher, but also the population is older than in meta-analysis by Song. This difference is also interesting. The authors of this study explain that by rapid urbanization, higher salt consumption, and this dysfunction in urban settings. Another study, Indonesian study, Indonesian adolescents. In this study, prehypertension was found in 17% of a group of adolescents, 15 to 19 years old. In all patients, the risk factors for prehypertension were sex, or boys 18 and 19 years old, and obesity. In girls, the risk of prehypertension increased with increasing LDL cholesterol level and increasing age. And the study published this year in February on a group of young Aboriginal and Torres Strait Islander people. In this study, including patients 10 to 24 years of age, prehypertension was found in 12% of people. In the multivariate model, the risk of prehypertension were higher for male than for female, and for patients, for people with obesity, than with BMI values in the normal range. It is difficult to assess prevalence of ambulatory prehypertension based on office and ABPM blood pressure values. However, based on our study published in 2020, we can say that ambulatory prehypertension can be diagnosed in about 10% of patients with elevated blood office hypertension. We know what is prehypertension, how often it occurs. We should have a look on these results to think if it's a mild phenomenon or can be related to hypertensive mediated organ damage. And we have a few very important papers on that. Some authors of these papers are here today, so again, it's my great honor to talk about that. The first one is the study by Professor Urbina analyzing cardiac and vascular consequences of prehypertension in youth. In this study, there was 65 patients with office prehypertension, and what is important, left ventricular mass index increased with increasing blood pressure status from normal tension, from prehypertension to hypertension. The same with parameters of arterial structure or function. Another also important study by Professor Staburi analyzing left ventricular mass index in also normotensive, prehypertensive, and hypertensive children and adolescents, and the same findings. Left ventricular mass index in group of patients with prehypertension, office prehypertension. This was ambulatory prehypertension. So both ABPM and office blood pressure values were taken into account. In patients with ambulatory prehypertension, left ventricular mass index was significantly increased, significantly higher than in normotensive patients. In our study, already presented parameters of hypertension-mediated organ damage, left ventricular mass index, CIMT, pulse wave velocity, were significantly higher in group of patients with ambulatory prehypertension, again, based on both ABPM and office blood pressure values. But what is also very interesting, parameters like stroke volume, cardiac output, and cardiac index were significantly higher in our ambulatory prehypertensive group compared to healthy normotensive population, or what can suggest some signs of hyperkinetic circulation in this patient. But we have, on the other hand, we have argument not to use blood pressure load, not to discriminate ambulatory prehypertension as a different blood pressure status. And there are also a few important studies on this topic. We all know them. The first one, CT study, where no clear benefit was found of using blood pressure load in addition to mean arterial blood pressure in predicting CKD progression or left ventricular hypertrophy in children with CKD stage 2 to 4. Another important study we all know, Shipahoy study, which showed that blood pressure load was not associated with LVH and did not improve prediction of LVH if added to the mean blood pressure levels. And now the evolution. We should think if this pre-hypertension status is a mild phenomenon, temporary phenomenon, or maybe it's only a step on the road to hypertension. First, very important study by Professor Falkner, analyzing more than 8,000 adolescents in whom single blood pressure measurements were obtained at 2-year intervals. And what happened after 2 years? First, this table. After 2 years of observation, 14% of patients with boys first, pre-hypertension at baseline, developed hypertension compared to 5% of patients normotensive, boys normotensive at baseline. In girls, 12% after 2 years developed hypertension compared to 4% of girls normotensive at baseline. After 4 years, 14% of girls and 15% of boys compared to 5 and 6% of normotensive developed hypertension. Regression models show no significant effect of race on blood pressure changes, but significant effects of initial BMI and changes in BMI. Another study from Israel included almost 27,000 of teenagers. They were screened first time at the age of 17, and then starting from the age of 25, the blood pressure was measured in this group every 3 to 5 years. The observation time was around 14 years. And using Cox regression models adjusted for age, BMI, stratified by baseline blood pressure, the hazard ratio of hypertension increased gradually across blood pressure groups. So in patients with blood pressure values corresponding to pre-hypertension, this risk was significantly higher than in patients with lower blood pressure at baseline. Another study from Israel, also very big group, 18,000 male regular army personnel. Patients recruited between 17 and 90 years old, and then the authors analyzed which of these patients developed hypertension between 26 to 45 years of age. And what is important, not only blood pressure played a role in this group. Of course, the risk of developing hypertension increased with increasing blood pressure status at baseline, but also BMI played a role. In patients with high normal blood pressure and normal BMI, the risk of developing hypertension, 9.5% of patients develop hypertension, but in obese patients with high normal blood pressure, 33% at the end of observation developed hypertension. To conclude, based on the studies conducted so far, it should be concluded that children with high normal blood pressure, elevated blood pressure, however we call it, differ from children with normal blood pressure. H-mood parameters in patients with high normal blood pressure are significantly higher than in patients with normotension. The risk of developing hypertension in adulthood in patients with high normal blood pressure during adolescence is significantly higher than in patients with blood pressure defined as normal. And taking the above into account, patients with high normal blood pressure should not be excluded from the observation. They should be monitored, and subsequent prospective studies on a larger group of patients may confirm or exclude the validity of such point of view. Thank you very much.
The range is defined as 120 to 139 or 80 to 89 millimeters mercury. This is frequently divided to two groups, 120 to 129 and 130 to 139 and 80 to 85, 85 to 89. And even if you divide pre-hypertension range to these two groups, you can find significant changes in risk, in outcome, when the higher group is at higher risk. Now, facts. Pre-hypertension is key predictor of future hypertension. This is well known, this is obvious. Identifying at-risk individuals allows for early intervention, and there is a dispute about intervention. It can be non-pharmacological and pharmacological. And more, when we gather data, we understand that pharmacological treatment should be used earlier than we used to do it today. Now, of course, understanding the mechanisms is critical for prevention and management. It is well known, and I will show you several meta-analyses confirming that increased risk of target organ damage is present, higher incidence of myocardial infarction and stroke, progression to resistant hypertension is higher, and there is a greater burden of cardiovascular morbidity and mortality. Let's talk a little bit about prevalence of prehypertension and progression to hypertension. This is a well-known old slide from '95, published by Bird, showing the behavior of blood pressure during the age changes. And you can see that the systolic increases constantly. The older you are, the higher your systolic blood pressure is, and we'll discuss the mechanisms later. The systolic reaches a peak and then decreases. There is a clear-cut physiological explanation for that, but we do not have the time now for discussing it. Now, a well-known fact is that small differences in pulse pressure become magnified with age. If we have a very few millimeters difference between two subjects, the one with 2 or 3 millimeters mercury higher blood pressure has greater chance to become hypertensive, to develop damage, and to need treatment. You can see on the left, young age, small differences, and you follow the lines, it becomes greater and greater as the patient ages. This is the prevalence of prehypertension by gender and race. On the left you can see men, then women. To tell you the truth, I read a lot about these findings. It looks questionable. I don't know, maybe the sampling was not very good, maybe there were different groups in different studies. How we can explain this huge difference between men and women? And also, Mexicans, Mexicans, African Americans, and white mean value. Why young women have so more than 50% less prehypertension? It's very difficult to explain. Maybe sampling will give us sampling error or sampling which is not as should be. It can explain that. Now, these are data from the Framingham study showing 4-year progression to hypertension. On the left, you see optimal blood pressure, relatively low number of patients that become hypertensive. In the middle, pre-hypertensives. In the right, hypertensives. So the higher your blood pressure is, even in the normal range, the higher the chance to become hypertensive within a relatively short period of time. What are the risk factors for prehypertension? Of course, age. Age is a major factor because it goes, as you've seen in the previous slide, goes linearly correlated to age. Obesity and metabolic syndrome affect the progression of increasing blood pressure and appearance of prehypertension in normotensive. Insulin resistance and diabetes, family history, high salt intake and low potassium intake, chronic stress and autonomic dysfunctions. So all these lead to hypertension, but also to prehypertension in the first stage. Prehypertension is associated with increased cardiovascular risk, and I will show you a few well-known data to confirm this. First of all, these are data from the Framingham heart study. The starting point in men and women on the left is similar, but the high normal group increases blood pressure more severely than the optimal blood pressure or normal group. So again, the higher is your blood pressure, even within normal range, you have a higher cardiovascular risk. It was calculated years ago, published in JAMA, that cardiovascular mortality risk doubles with each 20/10 millimeters mercury in blood pressure. So you can see that prehypertensive range, it carries with it almost a double cardiovascular risk compared to optimal and normal blood pressure. This is also ischemic heart disease mortality rate in each decade of age, and we can see clearly that the age causes increase in blood pressure to a very high level, increases also mortality and morbidity. What are the cardiac changes that we see in prehypertensive patients? Here on the left, you see left ventricular geometry, left ventricular hypertrophy, and you see the bar in the middle. These are prehypertensive patients, significantly higher rate of LVH than normotensives, and in hypertensive, it's still higher. On the right, you see diastolic function, and the upper part, dark part of the bar, are the severe changes. Those are relatively low in normotensives, higher in hypertensives, and still higher in hypertensives. So we have evidence of slow progression of cardiac damage according to blood pressure levels, and this is clearly seen in the prehypertensive group. Incidence of cardiovascular disease, you can see meta-analysis of many studies. On the top, cardiovascular mortality, on the bottom, coronary heart disease, and you can clearly see that optimal blood pressure is significantly better and carries lower risk of cardiovascular disease. Atherosclerosis. If we look at atherosclerosis, similar picture can be seen. In hypertensive patients, the risk for renal arteriosclerosis found in autopsies, it was the Hisayama study, was more than twice in prehypertensives when compared to normal blood pressure patients. Also, the kidney microcirculation shows similar data. Prehypertensives are well in the middle in the progress to more severe changes. Now, cardiovascular event rates, you can see here, optimal blood pressure, normal and hypertensive, and the event rates are significantly higher also after correction, from 4 to more than 7 in normal blood pressure, and high normal significantly higher. Again, meta-analysis of cardiovascular disease in prehypertension. Of course, all the meta-analyses show more or less, but they are consistent with decreased risk of cardiovascular disease in prehypertensive patients and increased compared to normotensive patients. The same with stroke, very impressive. You see the risk is on the right and favors optimal blood pressure levels. Additional study showing the reduction of stroke, similar like coronary heart disease. You can see that optimal blood pressure carries lower risk, while increased risk is evident in prehypertensive patients. What are the factors that participate in the changes, in the pathophysiological changes with raised blood pressure and with pre-hypertension? Of course, we have the participation of renin-angiotensin system, we have involvement of the vascular endothelium, we have involvement of the ROS, reactive oxygen species systems, inflammatory process, prostaglandins and CRP are increased, involvement of the autonomic nervous system, of the central nervous system, and of other mechanisms that are associated with activation, for instance, of renin-angiotensin system in diabetes, hyperinsulinemia, obesity, stress, and other. What are the major causes of increased blood pressure determinants of arterial stiffness? We have several players here. Structure of the arteries, function of the arteries, and mean arterial pressure. The structure is affected by genetics, chemical attacks, sympathetic stimulation, and other factors. Now, what happens to the wall of the artery during life? We call it elastin fatigue. Elastin fatigue is determined by number of cycles of pounding pressure that affects the arterial wall and cyclical stress. Number of cycles is heart rate. Cyclical stress is the pulse pressure. So the major factors that affect elastin fatigue are heart rate and pulse pressure, and they are associated with promoting the process of arterial stiffening. These are pictures. On the left you see normal elastin tissue, and on the right we can see what we call a fatigue of elastin fibers. They look differently, they function differently, they are associated with all these changes that we've seen in stiffening of the arteries, which are always associated with increase in blood pressure. We can summarize the mechanisms of arteriosclerosis as elastin fatigue, and then you see the changes which can be seen on the aortic wall microscopically and by various imaging methods. So arteries stiffen during life. The x-axis is time, and the arterial wall properties or stiffness is on the y-axis. The lines show us the blue line, normal vascular aging, slow rate of progression of stiffening of the arteries. In a patient with risk factors, it is the red line, and we always have opportunity to intervene. The earlier we intervene, the more successful we will be in preventing events. Of course, if we intervene, if you look at the top of the red line here, if the intervention is very late, we don't have much to gain. But if it's done here, we can still change the fate of our patient. This was published by a good friend of mine, Pierre Boutouret, and it shows the effect of age and hypertension on aortic stiffness. The more you go to the right, the arteries are stiffened. It is divided according to ages. The ages of the subjects are here. Stage of hypertension is here. So the older you are, the higher your blood pressure, the stiffer is your artery. This is a very interesting publication by Dagmara Herring, excellent Polish group that published this data, and they evaluated tracking of muscle sympathetic nerve activity and its relationship with blood pressure in subjects with prehypertension. So you can see here, this was the baseline beginning of follow-up of prehypertensive patients. After follow-up of 8 years, MESNA, muscle sympathetic nerve activity, increased during follow-up of 8 years. Now, this is very impressive, and these are data for specific patients. All of them increase, some of them very much, some of them less, like this patient, but generally, during following up of 8 years, we can see that the muscle sympathetic nerve activity increases and probably plays a major role in the stiffening of the arteries. Another factor that is widely studied for the last years is gamma-glutamyl transferase. It has been found that the level of this enzyme is proportional to the elastic properties of young patients with prehypertension. I'm aware of several groups that work on this topic that evaluate the possibility of intervention in the levels of this enzyme to determine whether this will affect rate of stiffening of the arteries. Maybe a kind of anti-aging, which today is used in many scientific and non-scientific conditions. So prevention and early intervention we should use lifestyle modification for sure. But in those that are prehypertensive, we have to give much more effort to convince them for lifestyle change, like diet, sodium restriction, physical activity, and weight loss, and of course smoking cessation. Pharmacological intervention in high-risk individuals is, in many cases, justified. How we can modulate the progress of arterial stiffness? Of course, antihypertensive drugs, but lipid-lowering drugs, anti-diabetic drugs, anti-inflammatory drugs, antiaggregants, and hormone treatment have been shown to affect the rate of stiffening of the arteries. So these are all options, and they will be chosen according to the specific patients that we see in our clinic. The conclusion that prehypertension is critical warning stage for future hypertension. Lifestyle intervention can significantly delay or prevent progression. High-risk patients may benefit from early pharmacological treatment, and ongoing monitoring and patient educations are key to the long-term blood pressure control. Now, the new directions in the near future are research of development of arterial de-stiffeners, whether medications, whether any other kind of intervention. This should lead to arterial anti-aging effect. And all patients with cardiovascular risk factors and evidence of disease should be treated. It is possible that in the future, aging will be treated to prevent and redress age-dependent normal arterial stiffening. There is a term of normal arterial stiffening because everybody stiffens his arteries with age. The rate of stiffening depends upon cardiovascular risk factors. Just to mention a very important study that the trophy study by Professor Steve Julius, a good friend of mine and ours, who unfortunately died about 1 month ago. In 2003, published in the New England Journal of Medicine, the trophy study, in which he was the pioneer of treatment of prehypertension in 2003. Because even today, we can dispute whether it is justified to medically treat prehypertensive patients. There is no agreement till now. I am convinced but many of you are not, probably. And he treated for more than 4 years 2 groups with candesartan A or B and placebo group, and he showed a beautiful decrease in development of hypertension after the follow-up. The blood pressure was, of course, significantly lower, and this is a very important study about the concept of treatment of prehypertensive patients. I have to admit, Steve was a good friend of mine, we met many times, and he convinced me, I don't have hypertension, but he convinced me to start candesartan. And I took it for maybe 20 years, since then, 2003. My blood pressure was around 110 and 120. Stopped it 1 year ago because my blood pressure went down to 100 and I started to be dizzy. So I had no choice. What I noted in my blood tests, after discontinuation of candesartan, my blood pressure went up to 115 and symptoms disappeared, but my uric acid went up, some metabolic components became worse. So ARBs have a lot of positive preventing effect, and I'm convinced that those should be among the first medications to be considered in treatment of prehypertensive patients. I believe they have to be treated. We can give them better life, healthier life, and prevent disease and aging. Although the dispute whether to treat or not today continues. Thank you very much.